The meeting of the subcommittee is called to order, and today we're having a hearing on prescription drug price inflation. Are drug prices rising too fast? And I'll first recognize myself for an opening statement. Every day in America, a life is saved, an illness is averted, or the effects of a disabling condition are mitigated thanks to the innovative medicines produced by the pharmaceutical industry. And I also think that it's important to mention the constructive role that the pharmaceutical industry and individual companies have played over the past few years amid various healthcare debates. The industry was an early and active proponent for the reauthorization and strengthening of S-chip, which we were finally able to achieve earlier this year. In addition, I want to recognize their efforts to ensure comprehensive health reform is enacted this year. While I know that we all have not seen eye to eye on every issue, I appreciate the fact that the industry acknowledged very early on that they have a stake in making sure health care reform succeeds, and they're willing to make a contribution towards paying for it. Unfortunately, for all the good the pharmaceutical and biotech industry do, it is often overlooked or eclipsed by reports of behavior designed to maximize profits at the expense of individual patients, employers, and American taxpayers. Indeed, according to a 2008 public opinion poll conducted by the Kaiser Family Foundation, negative views of the pharmaceutical industry appear to be driven by perceptions about the cost of prescription drugs and pharmaceutical company profits. The Kaiser poll shows that 7 in 10 adults say pharmaceutical companies are too focused on profits and not enough on helping people. And nearly 8 in 10, 79%, believe that high profits are a major factor in the price of prescription drugs, and the same proportion feels that drug prices are unreasonable. The poll further suggests that these opinions about prescription drug prices are driven by people's real-life struggles paying for drugs. 4 in 10 adults report some serious problem paying for medication. Either that is a serious problem for their family to pay for drugs they need, or not filling a prescription, or skipping doses because of costs. And new evidence suggests that prescription drug prices are increasing rapidly. Most recently, the New York Times reported on November 15th that drug prices had increased by approximately 9% over the last year, and by at least one analysis is the highest annual rate of inflation for drug prices since 1992. At the same time, general inflation, as measured by the Consumer Price Index, has fallen over the past year, which means that while people are paying less for other types of goods and services, they're paying more for brand-name prescription drugs at a time when they are least able to afford to do so. And if you know, millions of Americans are out of work, millions are losing their homes, millions are without health care coverage. So it should come as little surprise that members of Congress would be alarmed about the idea of drug companies raising prices at a time when so many of our constituents are already unable to afford the medical care they need. Now, some researchers, including Dr. Schondelmeyer, who we're going to hear from today, have suggested there is a link between spikes in prescription drug prices and when there's legislation pending that impacts the pharmaceutical industry's bottom line, such as the various health care reform bills currently moving through Congress. I know that the pharmaceutical industry disagrees with this claim and has suggested that any increases in drug prices are a result of investments in research and developments that are necessary to keep new and innovative drugs moving through the pipeline. And I would be unfair if I didn't point out the industry, that this is not, how should I say it, one broad stroke. I mean, there are companies that are increasing prices and there are others that are not. But according to Dr. Schondelmeyer's research, some drugs saw no increase, some increases were below the average, but other drug prices increased by almost 20%, such as Flomax, which appears excessive in my opinion. Furthermore, these surveys on drug prices are unable to account for discounts and rebates provided by manufacturers to wholesalers or purchasers. Hence, there is a level of uncertainty that is inherent in these numbers, and that's why we're basically supportive of better price transparency. And when it comes to prescription drugs, I think that that's something that we really need more transparency, and I've been advocating that for a long time. I think that better reporting and more transparency will help us make sure that drug prices are not rising arbitrarily or to maximize profits, and that every American has access to affordable prescription drugs. And that's a goal that we all share. So we're here today to try to get to the bottom of this latest price increase, and we obviously have people that will be talking about some of the reports that have come out and also from the industry. And so I want to thank our panel of witnesses in advance for being here today. I do have to mention, though, that I know there's some issue with regard to Dr. Schondelmeyer because we just received his testimony this morning at 9:30, and I'm very upset by that because the rules actually provide that we have to have the testimony much sooner. I think it's 2 days' notice. When we get it the last minute, literally is the last minute, I know there's some members here that are going to suggest that he shouldn't testify at all. I was sort of inclined initially to say that as well because I haven't had anybody that submitted their testimony so late. But I would ask, I guess it's my prerogative to make the decision, and I am going to ask him to speak this morning only because a lot of this hearing came about because of his initial survey, and I think if we don't have the opportunity to hear from him, the panel and the hearing this morning won't be as productive. But I don't want to sound like a teacher chastising a student or something, but it is a problem when we get the testimony this late. So,
would the chairman yield for 1 second?
Yes.
Just trying to understand the historical aspect of this. Did this happen last year with another health care briefing from Dr. Schoenmeyer, and where we didn't get the briefing, but all we got was a PowerPoint?
You know, I'm not sure. I know that, look, let's be honest, and I don't want to get into an argument with anybody because I agree with you. Unfortunately, we are getting testimony late. Like I know that one of your witnesses, I think, we got it yesterday, which is not as bad as getting it the last minute. But it is getting to be a pattern that, we're getting some of this testimony, a day earlier rather than 2 days. And so I think we need to be a little more, I don't know what the word is, tough on the witnesses and remind them that we need it 48 hours in advance.
If the chairman yield just for 1 more second.
Sure.
It's my understanding that last year in the Government Reforms Committee, the same thing happened. And
I'm just told that he hasn't testified.
My issue is it's a pattern now. It's not one time.
Well, not in his
mistake.
case.
I'm just making a point that it might be a pattern. And
well,
we ought to be a little bit more.
He's not testified before, so I don't want to say that it's a pattern on his behalf. But I do want to mention that it is important for witnesses on, both Democrat and Republican witnesses to try to get the testimony in, not just, even 24, but 48 hours. The rules provide for the 48. But anyway, let me yield to our ranking member, Mr. Deal.
Thank you, Chairman Plum. Thank you for holding this hearing on the cost of prescription drugs. If the subcommittee is intent on addressing the high cost of pharmaceuticals, I believe that approval of the follow-on biologic legislation, which fairly balances consumer access with strong incentives to innovate, is essential to achieving this goal. In 2007, global sales of these drugs reached $75 billion. Current estimates suggest that half of all drugs, both small and large molecule-based, will be biopharmaceuticals next year, while statistics further indicate that spending on biologic drugs is expected to grow 20% annually. It is very disappointing that this committee, during markup of health reform legislation earlier, fell short on its commitment to achieve this goal. Unfortunately, provisions which aim to truly encourage competition, reduce cost, and most importantly, increase access to critical drugs that currently fall out of the reach of countless Americans every day were not included as a part of the bill, as Chairman Waxman and I both tried to get done. Instead of government price controls, which have a proven track record of declining research and development spending among those nations who have adopted it, appropriate incentives which spur research and development and enhance access to cutting-edge drugs is essential. As we all know, incentives to invest in R&D projects are highly dependent upon legislation this Congress puts into place. We must ensure appropriate provisions are put in place which continue to promote world-class pharmaceutical research and development in the fight for new cures here at home and abroad, while ensuring continued access to these drugs by the American people. It is indeed a delicate balance. I also look forward to AARP's testimony and appreciate the opportunity to discuss their decision to support H.R. 3962, particularly in light of significant cuts which are prescribed by the legislation within the Medicare program. I look forward to learning more about the reasons that led them to endorse this health care bill, which, as Chairman Waxman and I would probably say did not embrace some of the cost savings in the pharmaceutical area that perhaps it should have included. Again, thank you, Chairman Pallone, for holding the hearing today. I yield back my time.
Thank you, Mr. Deal. Chairman Waxman.
Thank you, Mr. Chairman, for holding this hearing. This is an important hearing. We're in the process of reforming health care, and one of our goals in doing so should be to hold down costs. Well, our economy is in a slump. The consumer price index has actually gone down, yet for pharmaceutical prices, in the last year, there's been a 9% increase. I must say that when it comes to prescription drugs and the drug industry, nothing surprises me anymore, but increases of this magnitude is really pretty shocking. Our nation sees that when drug prices are raised by 9% or more over a year, that increases the out-of-pocket cost for drugs. It drives up insurance premiums. It increases the cost of the Medicare D program. It means more and more citizens, some with insurance, some without, are forced to go without the drugs they need to remain healthy. And reports indicate that this problem is getting worse, not better. The drug price increases over the last year are the biggest we've seen in a very, very long time. It's hard to escape the conclusion that the industry is positioning its pricing for enactment of the new health reform legislation. They were met with great acclaim when they announced with the White House and the Senate that they were going to take an 80% reduction in their profits over the next 10 years, $80 billion. Well, a 9% increase in prices over this last year comes to $20 billion that they're getting in just 1 year. So let us keep this in perspective. When Americans hear about these soaring drug prices, they're absolutely right to demand to know what Congress is doing about it. In the House, led by members of our committee, we're trying to tackle this problem. Last month, the House passed historic health care reform legislation, and I'm confident the Senate's going to follow our example in a very short period of time. In our legislation, we provided that the health insurance, including drug coverage, for 36 million citizens who would be otherwise without it, and we closed the Part D donut hole, meaning that seniors would no longer have to stop taking drugs when their coverage runs out. What we did in the pharmaceutical area is that these companies will not just get a blank check as we reform our healthcare system. We try to strike an important balance that put consumers and taxpayers first. We require the drug industry to provide additional discounts for the Medicaid program. We end the multi-billion-dollar windfall that the industry received when dual-eligible enrollees were switched from Medicaid to Medicare Part D drug coverage. We're requiring the discounts be provided when the government pays for low-income people to get health care coverage. The House bill uses this money that would otherwise go to the drug companies to help millions of Americans afford health care coverage and to close the Part D donut hole. That's a good policy outcome. It's good for America, and it's the right prescription for pharma. The drug industry made over $50 billion in profits in 2008. $50 billion in profits. Some of that went to increase their research and development. Most of it, or let's put it this way, more of it went to marketing drugs than into R&D. So when we look at a drug price increase of 9% over the last year, it's the highest increase in recent memory. And as we try to climb out of our massive recession, as more and more Americans struggle with the loss of health care coverage and high insurance costs, everyone has to pay more costs for drugs. This is not right. We can't afford it. The drug companies are playing a shell game when they tell us they're going to take reductions in government expenditure, yet they're going to get millions of new customers paying for drugs, and yet what we see is at the same time they're increasing their drug prices at a record rate. I hope this hearing will help us inform the people who are working on health care reform so that we don't let them get away with this blank check. Thank you, Mr. Chairman.
Thank you, Chairman Waxman. The gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman, and I do appreciate the Chairman of the full committee's letter requesting a CBO analysis. I just wish we had that in hand prior to having this hearing, which he speaks of the timing of this hearing for the purposes of whatever the majority wants to deem without having a proper analysis. Having said that, Medicare D has been one of the most successful federal health care programs. Originally scored in first year cost at $49 billion. It came in at $41. Overall, since its inception, it's 40% under projected cost. Seniors have more choices, and it is a distinct difference in the direction that we're heading in 3962, where Medicare D incentivizes private insurers to provide access to prescription drugs for people can choose. And you let the market work, which is just the opposite of what we plan to do when we eventually move to a government takeover of health care in 3962. Every health care hearing that we're going to have is going to be, as the chairman of full committee says, in the parameters of the health care bill that's moving through both chambers. And rightly it should be. So there'll be a lot of great questions because of the calling of this hearing, and we look forward to discussing those. Let me end on just talking about comments made last week, which was disparaged but was been proved correct by a paper called The Californian. Last week we had the breast cancer decision from 40 to 49, and a lot of us said this will start the road down to the government making determinations based upon cost. And the headline here is state ends subsidy for mammograms to low-income women under 50. And they also say the state's decision announced December 1st and effective January 1st follows a controversial federal recommendations last month that mammograms before the age of 50 are generally not needed. However, the private health care system has rejected the federal task force recommendations. So here you have the public health agency say, we're going to accept these to save cost. The private insurers are going to keep them, which is an incentive for us to stop disparaging private insurance and really be concerned about government run. Here's what Dr. Clausen says. What makes me really worried is that the California Department of Public Health wants to save money by taking away a cancer detection program, Clausen said. That discriminates against a gender, also discriminates against an income level, and it also discriminates against how community clinics can practice medicine. That is the road we're heading. I reject this path. It'll be harmful to public health, and we'll get a chance to ask questions of those people who are in the room, the closed-door meetings with the White House and other leaderships on their role in H.R. 3962, and I yield back my time.
The gentlewoman from California, Ms. Eshoo.
Thank you, Mr. Chairman, for holding this very important and timely hearing today. Like most of my colleagues, I too am very concerned to see reports of artificially increased drug prices on the heels of a promise made by the drug manufacturers to decrease prices for consumers. Last month, the AARP released a study which found brand-name drugs increased by 9.3%, the highest drug inflation since 2002. Just a few months earlier, a much-touted announcement by the White House and Pharma promised $80 billion in savings on drug costs, most notably to help seniors who are struggling to pay for medications in the donut hole. At a time when everyone in the healthcare industry is being asked to put something on the table, to contribute something to the reform effort, The drug companies were some of the most vocal in touting the, quote, sacrifice they were making for the cause of health care reform. Last April, IMS predicted that drug sales might actually go down. But IMS Health, a consulting firm paid for by the drug companies to advise them, reported a significant increase in prices. I certainly understand the need to couple profits with innovation in order to promote science and encourage new therapies and treatments. I think that that is essential, not only for to advance what we want to advance, but that we retain an American position where we're first in the world because our people benefit from it. But as I understand it, the House Pharma Agreement called for reduced drug costs to support comprehensive health care reform and not from discounts from jacked up prices. I know that we're going to be hearing from pharma, who I understand will testify that reports of rapidly increasing drug prices are false and that the increase was based solely on the listed price of drugs, not the discounted prices most Americans or the government pay. I'm eager to hear their explanation and be able to report these explanations back to my constituents, if they're worthy of being reported, if they really hold something. I'm also eager to hear from AARP, which fueled much of the drug pricing debate with their recently released report. As both an interest group for seniors and an insurance company, their report may have different implications. I would just like to add, too, that the gentleman from Georgia made some comments about biologics, and I know that he's not pleased with the outcome of what's in the bill. I do believe very, very firmly that by treating biologics in a new way, bringing them into biosimilars, that this will keep or make biologics, move them into generics, and thereby more and more Americans will be able to not only afford them, but that pathway is a very robust one, a smart way to go. I don't want to lose this to other countries. I think that America is in a position today where it can ill afford that. And most frankly, we have two major biologics companies today. We have to do this the right way so that this can reach patients, and it really represents, I think, the most hope in medicine, because as good as pharmaceutical drugs may be, they only treat symptoms. They don't go to the cause of a disease. So biologics are really where the most hope lies. So I thank you again, Mr. Chairman, for holding this hearing. I look forward to the testimony, the important testimony of the witnesses, and I yield back.
I thank the gentlewoman. Gentleman from Indiana, Mr. Boyer.
I thank the Chairman for the hearing today, and I don't mind receiving input from anyone at this point. Because there's such great uncertainty out there, especially regarding your very aggressive health agenda. And it's an agenda that I think is on the verge to hurt the industry in which we're going to discuss here today, and they're in turn hurting the health of America and the world. I think it's important to look at what we know about drug prices and their relationship with regulations such as price controls, which are supported by the majority. It's what's included in their health reform legislation that passed by the House and is being debated by the Senate. What we ought to be doing is we ought to be looking at the effect of price controls, and we can look at the model that is by European countries between 1986 and 2004. During this time, these countries strengthened their price controls, and the controls had a devastating impact upon research and development spending. And all of that investment then began to shift to America. Before the strident price controls were implemented in the mid-1980s, spending in Europe for research and development of the new life-saving drugs exceeded that of the United States by 24%. By 2004, spending in Europe on research and development of drugs trailed the United States by 15%. So what did this dramatic decline in research and development investment in Europe amount to? Well, they have 50 fewer new drugs approved in Europe and about 1,700 fewer scientists employed in Europe. Europe's pharmaceutical industry research and development grew at merely 1/2 of the rate of that here of the United States. As economists John Vernon and Joseph Golick found, quote, whereas European Union firms introduced about twice as many new medicines as U.S. firms between 1987 and 1991, they introduced about 20% fewer than U.S. firms between 2000 and 2004. So here we sit with potential price controls that will be similar to Europe. I think America ought to pause. Actually, I think America ought to wake up, because there is a wave of socialism that is truly coming to the shores of America, and we better wake up. Now, all of us either have friends or someone or a family member that has a narrow disease. So when you think of types of narrow disease, adenoid cystic carcinoma, Alpers disease, Bell's palsy, Dandy Walker malformation, Hodgkin disease, sickle cell disease, sudden infant death syndrome. There's a very long list. And so what is the demand when someone has a narrow spectrum of a disease? Well, they want the pharmaceutical companies to find that drug that can help. Well, if it's very narrow and there's not the ability to have a profit, what is the incentive for industries to go? So government tries to provide the incentive. If we're going to wipe out and move to price controls and wipe out incentives and R&D, then many of these disease groups, people are going to be left on the outside. And that is not how we define compassion for public health for America. I yield back.
Thank you. Gentleman from Texas, Mr. Green.
Mr. Chairman, thank you for having this hearing on prescription drug prices. We've seen many reports on high cost and rising prices of prescription drugs. The most recent report was released by ARP Policy Institute in November, found that between October 2008 and September 2009, the brand name drug prices increased 9.3%, the highest drug inflation since 2002. Prices for specialty drugs used by Medicare beneficiaries increased even more by 10.3%. Over the same time, prices for generic drugs declined by 8.7%. The high cost of these prescription drugs has an impact on Medicare due to the increased taxpayer expenditures and increased premiums. I'm also concerned that every member of this committee has heard from seniors in their district who enrolled in Medicare Part D have fallen into the donut hole, which is a result of the Medicare Modernization Act of 2003. This forced Medicare Part D enrollees to pay 100% of drugs between $2,700 and $6,154. Each year, 4,400 seniors in our district hit the donut hole and are forced to pay their full drug costs despite having Part D drug coverage. Throughout the country, seniors pay thousands in out-of-pocket expenditures they are unprepared for with fixed incomes. The donut hole often causes seniors to choose between purchasing medication and food, which is not something they should ever have to do. This is not the kind of benefit seniors deserve and needs to be corrected by Congress. The House passed a health reform bill, H.R. 3962, which makes several major changes in prescription drug programs to ensure seniors and low-income individuals receive the prescription drug medication they need at an affordable cost. H.R. 3962 increases current Medicaid drug rebates that manufacturers pay to the government and closes a program loophole that prevent full rebate payments. It also ensures the drug prices for dual eligible and other low-income enrollees are no higher than Medicare Part D than they are under Medicaid. H.R. 3962 reduces the donut hole by $500 immediately and institutes a 50% discount for brand name drugs in the donut hole upon passage. It actually eliminates that donut hole over a period of years by 2019. The legislation gives the Secretary of HHS the ability to negotiate with pharmaceutical manufacturers to get the best deal possible for Medicare Part D beneficiaries. This allows the Secretary to obtain large discounts and rebates on drugs used by seniors, passing on that savings to Part D enrollees and to the taxpayers. The Senate is working on their health care bill right now, but their bill does not allow the Secretary to negotiate the lower Part D prices. and does not create new Part D drug rebates and does not close the Part D donut hole. If we want to make real health care reforms, we must address the problems that exist in Medicare, particularly those that cost our seniors thousands of dollars each year. And again, I want to thank the witnesses and appreciate them for hearing for our committee, Mr. Chairman.
Thank you. Gentleman from Georgia, Mr. Gingrey.
Mr. Chairman, I'll waive my opening statement in the interest of having more time for questions. Thank you.
Thank you. Our Vice Chair, gentlewoman from California, Ms. Capps.
Thank you, Chairman Pallone, for holding this hearing on such a timely and urgent situation. As we move forward with health care reform efforts, we need to ensure that we aren't just providing access to health care services in theory, but we need to actually make it affordable, both for individuals and for the government. With prescription drugs accounting for 10% of medical expenditures, it's imperative that we assure affordability for the people who rely on them. I'm particularly concerned with the impact of rising drug costs on our seniors, who, for the most part, live on fixed incomes. I'm sure all of our colleagues have heard from constituents who've literally had to decide each week between medication and groceries because the costs are so prohibitive. Or other constituents who decide to take only half of their prescription, their dosage, because they can't afford to pay for the entire amount. While there are assistance programs to help individuals pay for their medications, they aren't always reliable, and they don't always apply to the particular medication that the senior needs. And that's why it's so important that we have this hearing today to look into the possible reasons for the rapidly increasing costs of medication. Certainly understand that drug manufacturers must recoup the expensive costs of research and development. But at the same time, isn't it unconscionable for us to be watching as drug companies' profits rise the way they are, while more and more of their patients with chronic disease lose their ability to afford life-saving medications? I look forward to hearing our witnesses' thoughts on why these price increases are occurring and how we can address the situation, the costs, as we move forward. And I yield back. Thank you.
Thank you. Gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. I'm sure if there are people watching this hearing this morning, they're wondering what in the world is the purpose of what we're doing here this morning. If it is to answer the question, are prescription drug prices rising too fast, then they probably have a couple of concerns. And the first is, why have we not waited until the report requested by Chairman Waxman from the General Accountability Office on this very question was received? We really can't debate the proper increase in prices, what they should look like, until we know the facts, not the facts as reported by the New York Times or an advocacy group with a policy agenda, but that provided by an independent entity which has the responsibility of providing Congress with information. And the second concern is, why in the world did we not initiate this in the Subcommittee on Oversight and Investigations, where we have subpoena power if necessary and can take testimony under oath? If the concern is that prices are being manipulated and causing harm to Americans on programs under this committee's jurisdiction, then that would seem to be the natural place to hold that hearing. Maybe this is all about that monstrosity of a bill that we passed late in the night a couple of Saturdays ago. Again, it's just hard to know. But you do have to ask the question, where is the General Accountability Office? Where's the Congressional Budget Office? Where are the actuaries at the Center for Medicare and Medicaid Services that could make sense of some of this for us? None of those people are testifying today. Mr. Chairman, why is that? Now, I know some people look at drug prices and say all drug companies are evil and they shouldn't make a profit and we need to take those away from them. This government's history in the past year of manipulating in the market is wrong on so many principles. I don't think we should encourage that type of behavior in this committee today. But you know what we really don't know? If this manipulation does exist, what part of it was fostered by those secret negotiations that occurred down at the White House in May and June? And why has this committee had absolutely no curiosity about what was going on in those secret negotiations in May and June? And why is it that so many of these things were stumbled upon in hearing in the right workup of the legislation in this committee and on the Senate Finance Committee? Why is it that pharmacy prices can't be changed? Why is it that the American Hospital Association has some of the things that it's brought to the table that are judged to be pre-tax? What other deals were struck? What deals with the AMA? What about AHIP? What about the Service Employees International Union? We know nothing about that because this committee has had no curiosity about what might have been happening down at the White House under the cloak of darkness. This was supposed to be a transparent process available to the American people on C-SPAN from start to finish. And we can't get the most basic information about what was given up and what was given away during those secret negotiations in May or June. Now, we can also do a lot of stuff on Medicare Part D. Got to tell you that the fact that we decided in 2006 to work with the market rather than dictate to the market has been responsible for a significant amount of success in the Part D program, but I suspect we'll hear some of the same arguments that we've heard for years about why that program is not working, despite the fact that 90% of Americans age 65 and over have access or have prescription drug coverage today, compared to 75% before we started in 2004, and that the satisfaction with that program is at an all-time high. Not going to say that the program can't be improved, but it has worked and it has exceeded expectations, and I think we need to be careful before we start tinkering around the edges with that program. Thank you, Mr. Chairman, for having this hearing. I yield back.
Thank you. The gentlewoman from California, Ms. Harmon.
Thank you, Mr. Chairman, for holding this hearing. Let me say to Dr. Burgess that I sat through the tens of hours of markups of the health care bill, and I heard people on our side complain fiercely about the so-called deal that the White House struck with pharma, the $80 billion deal. And I remember voting for parts of the health care bill that were reported by this committee that scuttled that deal, and that required, for example, negotiations for better drug prices under Medicare Part D. So I think whatever it is that the White House did, I want to applaud this committee for looking independently at some of those deals. And I think the reason we're here today is because we're still enormously concerned about the escalation in drug prices. According to the AARP, the wholesale prices, not the retail prices, of brand name drugs have risen by 9.3% in the last year, the highest annual increase since 1992. And this comes at a time when the consumer price index has dropped by 1.3%. As we head into the holidays and people are strapped to buy anything for their families over the holidays, I think it is just unconscionable and immoral that a basic necessity of life, which is drugs, is having this unexplained escalation in prices. We already spend nearly $300 billion a year on prescription drugs. It is one of the fastest growing areas of healthcare spending, and frankly, since the very beginning, I have maintained that reducing the cost of prescription medications is the one reform that will have the biggest impact on people. So I'm very glad that we're holding this hearing, and I just want to say to our witnesses and to others who are looking at this problem that consumers are watching. And right now, what I think they're seeing is price gouging. I yield back.
Thank you. The gentleman from Pennsylvania, Mr. Murphy.
Thank you, Mr. Chairman. This is a hearing that I think we've long awaited, as with many other hearings of this type, to find out accurate information with regard to pharmaceutical companies and what they do. I'm particularly concerned here about making sure that we are not having hearings on why drug companies are not inventing drugs to cure disease. That would be a sad state of affairs indeed. Many of my constituents are senior citizens, and we know they struggle to pay their high medical bills. We know that we've had opportunities, sometimes squandered, with regard to how we could reduce medical bills by reducing costs of health care through preventative services, through making sure that we maintain disease management, by making sure we reduce waste in health care. However, one thing we don't want to do is eliminate drugs that can help cure problems. After all, drugs that are not affordable offer little consolation, and a drug that is not invented offers little cure. And as a combined thing, we have to make sure this committee does not stand in the way of coming up with those cures. It's easy to go after companies that make money oil companies, pharmaceutical companies, anybody else who makes a profit as a for-profit or non-profit company, and say that they should not be making that kind of money if the cost is passed on the consumer. I understand, and we need to be sensitive to that area and make sure that these prices of any item is not inflated to the point that people cannot afford them. However, it's also important that this committee nor this Congress nor this country stands in the way of coming up with these cures to treat diseases. There was certainly in other things that we have done here. We've looked after the consumers. We want to make sure we continue to look after the consumers and making sure that these are things that they have. Generic drugs also are a critical function. They have grown massively in their use. They provide some good choices for people, and we need to continue to support generic drug use. However, they are not involved in the research and development sector, and we have to make sure that the research and development continues on. Congress funds much of that through NIH, through NIMH, through a lot of studies that take place, and we need to continue to do that as well. And somehow we have to look at how combining these efforts to fund research and development, to fund all levels of research, continue on so that this country leads the way in coming up with ways that we can find affordable prescription drugs. And to that end, I'm looking forward to hearing the testimony of the panelists here and seeing if they can offer us some solutions that's based upon how we can maintain this search for cures as well as search for affordable costs. I yield back.
Thank you. Gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Chairman Pallone. I appreciate your having this hearing today to better understand why prescription drug costs are rising exponentially at a time when millions of Americans are struggling to make ends meet. I assure you, my constituents applaud the fact that we're having this hearing today. A recent AARP survey of Illinois seniors confirmed the concerns that I hear from my constituents every single day. 63% of AARP members in Illinois said they were concerned about affording their prescription drugs. Close to 20% reported having to cut back on necessities to pay for prescriptions. 21% reported not filling or delaying a filled prescription because they simply couldn't afford it. And 1 in 5 said they took less than the prescribed amount to make their medicines last longer. Facing a severe budget deficit, our state took the bold step of expanding its prescription drug program called Illinois Cares RX, designed to benefit seniors and people with disabilities. When asked about the reason for the expansion of the Illinois Health, when asked for a reason, we asked Barry Miram, who is head of the Illinois Health Care and Family Services Division, and he said, quote, "The cost of prescription drugs has escalated to the point of being unaffordable for many of the people who rely on them most, especially seniors and people with disabilities. No one should have to go without medication that keeps them healthy," unquote. The cost of brand name prescription drugs are rising at a pace that far exceeds price increases for other consumer products. My constituents, both as consumers and as taxpayers, want to know whether the pharmaceutical industry is preparing for health care reform by trying to squeeze every bit of profit they can now. Health consumers are desperate for health care reform, and there are many provisions in H.R. 3962 that would lower drug prices, including the language that I had the honor of offering to this committee to eliminate the ban on Medicare negotiating for drug prices. But they can't afford to have the drug industry use the time between now and the implementation to artificially raise prices and profit at their expense. Again, I thank you, Mr. Chairman, and I yield back.
I thank the gentlewoman. Next is the gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman, and I appreciate you holding this hearing today. I'd like to be able to say that I'm shocked that we're here talking about this, but sadly I'm not. Americans pay the highest drug prices in the world. We pay between 35% and 55% higher than people in other developed countries, and we've been paying these exorbitant prices for a long time. Drug prices account for 10% of all health care spending. Over the past year, we've been working hard in this committee and in Congress to make health care more affordable for families, businesses, and individuals, and the Affordable Health Care for America Act healthcare bill contains a number of initiatives aimed at curbing the out-of-control drug prices for America's families and seniors. And yet, during this period, drug companies increased prices by over 9% at a time when inflation was negative. Increased drug prices hurt us all. They hurt older Americans on fixed incomes who saw their drug bills increase by $550 last year. They hurt people who have insurance and who now have higher copays. They hurt taxpayers and the government who are now paying higher drug prices. And more than anyone else, they hurt the uninsured who do not have anyone to negotiate on their behalf. There is something wrong when Americans are paying record high drug prices and drug companies are reporting such high profits. The CEO salaries at some of the largest drug makers are evidence enough that something is seriously wrong. At Abbott Laboratories, the CEO made over $28 million last year. At Merck, the CEO made over $25 million. And at Pfizer, the CEO made over $15 million. And it does not end there. Drug companies often claim that they must charge higher prices in order to fund research and development for new drugs. But the truth is, drug companies spend more on advertising than they do on R&D. It's time for some answers. It's time for the drug companies to explain why they're raising prices, especially right now. And I yield back.
Thank you. Gentleman from Pennsylvania, Mr. Pitts. Waves. Gentleman from Georgia, Mr. Barrow. Thank you. I think that concludes our opening statements from the members. So we'll now turn to our witnesses. We have just one panel today, and I'd ask the panel to come forward at this time. Welcome, and thank you for being here today. Let me just introduce each of you. Starting on my left is Professor Stephen Schondelmeyer, who is professor and head of the Department of Pharmaceutical Care and Health Systems and director of the Prime Institute at the University of Minnesota. Second is Mr. Rick Smith, who is senior vice president for policy research and strategic planning at PhRMA, which is the Pharmaceutical Research and Manufacturing Association. And then we have Kathleen Stoll, who is Deputy Executive Director of Families USA, and Dr. John Vernon, who's Professor, Department of Health Policy and Management at the University of North Carolina at Chapel Hill, and he's a Faculty Research Fellow with the National Bureau of Economic Research. And finally is Ms. Bonnie Kramer, who is chair of the Board of Directors of AARP. Thank you all for being here today. We have 5-minute opening statements. They become part of the record, and you may, of course, with our discretion, submit additional statements in writing, and you may get some additional questions after the hearing to respond to in writing. And I'll start with Dr. Schondelmeyer. I think your mic is not on.
Yes, thank you. Mr. Chair, and my apologies for being late with my testimony. I was rather pressed with time and short notice on this particular hearing. I'm here to speak on my own behalf as a researcher and one who's studied this marketplace for more than 30 years. I'm not here representing AARP or even the University of Minnesota, other than the fact that I'm a professor there, and that's where I do my research. And also let me comment that the Medicare Part D drug program has expanded coverage for prescription drugs for people who would not otherwise have had such coverage, and it has provided many benefits. And we've made some progress in that area. Realizing that drugs and drug prices and drug expenditures were an issue, the AARP and others, such as myself, researchers in the marketplace, determined that we need to kind of follow the advice, for example, of President Reagan when he said, with respect to nuclear disarmament, trust and verify. One, let's trust that there is a reason for the price changes, but let's track them and see what they are, and report that and reflect those price changes in the marketplace. And so individuals at the AARP Public Policy Institute had an interest in tracking drug prices, and I've been doing that for a number of years in the marketplace,
and we decided to get together and collaborate. That collaboration has led to a series of studies of drug prices over the last 5 or 6 years with AARP, one of which was the study that got reported in the New York Times back about a month ago. The details of that study and how we conduct our reports can be found in the reports that are available on AARP's website, and so the detailed methodology, I would refer you to those reports rather than take time today to go through them, but I'd be happy to answer any questions. Just to put in perspective, though, we use actual Medicare Part D prescription data and identified the most frequently prescribed, the highest expenditure drugs, and the drugs that accounted for the most days of therapy. And with 548 individual drug products in our market basket, we were able to account for over 81% of all prescription expenditures under Medicare Part D, over 79% of the prescriptions dispensed, and over 91% of the days of therapy. So this market basket represents virtually all of the Medicare Part D market, with the exception of a very small set. The data that we use is a price called the wholesale acquisition price. And let me remind you that wholesale acquisition price is a price that is set by the manufacturer and reported to the price databases such as Blue Book, Red Book, or Metaspan. And these prices are the manufacturer's set price. On the one hand, even the wholesale acquisition cost is, in a sense, a type of a list price, but this list price very directly affects the price that's paid for prescription drugs at the retail level for virtually all third-party programs in the U.S., including the Medicare Part D plan, which is in the private market as well. So let's get down to the meat. What has the trend been for prescription drug prices in the past year? And here we're comparing prices from October of 2008 up through September of 2009. So I'm talking about annualized prices, a 12-month period. And we use a rolling average, which actually levels out and actually pulls down, in some cases, the price increase that's reported. Brand name drug prices, that is largely patented single-source drugs, increased on average from this Medicare market basket 9.3% in the 12 months ending in September 2009. That 2009 increase of 9.3% was the highest that we've seen in at least 7 years prior to this for that same market basket of drugs. The previous years we saw 5.3 to 8.7% increases. Nothing to brag about, but now we're up to 9.3%. The average cost of just one brand name medication, if a patient is taking it on a chronic basis, would be over $2,000. And this 9.3% increase then means that the individual taking just one chronic medication experienced a $200 increase in the cost of that medication last year. The average elderly person is on 2 to 3 medications, so they would have experienced $400 to $600 increase in expense. 96% of the brand name drugs that we tracked experienced a price increase. None had a price decrease. The annual price increases of individual brand drugs that were notable, and there were many, and I'll only give a few examples. Ambien CR, a heavily advertised drug, increased 20.8%. Aricept, an anti-dementia drug with generic competition, increased 17.2%. Zetia, a drug with a questionable value and efficacy, increased 14.3%. Nexium, a heavily advertised drug with a patent until 2020, increased 7.1%. That's brand name drugs. We also pulled out specialty drugs. These are often the drugs you're talking about in terms of biologicals or biosimilars. Not all of them are, but the vast majority of specialty drugs are biologicals. The biologicals and specialty drugs experienced a 10.3% average increase in 2009. And there we can look, for example, the drug beta-seron used for multiple sclerosis had an increase of 28.2%. There were 5 drugs, actually 4 drugs and 5 different presentations of those drugs in our market basket. All 5 of the multiple sclerosis drugs increased more than 17%, ranging from 17.5% up to 28.2% increase in price. There were 12 cancer drugs in our specialty database. They ranged from a low of 4.9% up to 20.88%. And again, remember, inflation overall was negative last year. The bright spot is we also track generic drugs, and generic drugs actually went down 8.7%. This is one of the few sectors.
I'm going to ask you to summarize because you're like a minute and a half over.
Okay, I will. Generic drugs are one of the few sectors that truly has a marketplace and has economic competition, and generics have continually gone down in price. The question isn't what do we use to measure price inflation, the Consumer Price Index for RX drugs or the AARP index. Each of them provides information that's unique and different. Our index was created to show the difference between brand names and specialty and generic, not just the aggregate index. And my full report, and I would be glad to answer in questions, the role that rebates and discounts and that other methodological issues have in how we view this. The bottom line, though, is the average senior last year got a 0% cost of living increase for Social Security income. They experienced an 11% increase in the premiums they had to pay for their Part D plans. That's for the drug benefit plan. They also face a 9.3% for brand name and 10.3% increase for specialty drugs. And the only bright spot there is the 8.7% decrease in generic drug prices. These prices are real. They are felt by your constituents.
Thank you. Mr. Smith.
Thank you, Mr. Chairman. Mr. Chairman and Ranking Member Deal, members of the committee, thanks for the invitation to testify today. CBO reports that pharmaceutical research sector is one of the most research-intensive industries in the United States. Companies' investment in discovering new medicines is yielding results. Also, according to CBO, many examples exist of major therapeutic gains achieved by the industry in recent years. The rapid increases that have been observed in R&D spending have been accompanied by major therapeutic gains. Extensive research also reports that medicines often reduce spending on other healthcare services. The committee requested that I provide information on prescription drug pricing. As a trade association, PhRMA maintains a strict antitrust compliance policy. We can neither obtain nor discuss our members' proprietary information related to prices, negotiations, or discount strategies. My testimony, therefore, reflects only aggregate market data and publicly available information. Recent government reports demonstrate that prescription drug cost growth has slowed dramatically. Findings about drug costs in the government's most recent national health expenditures data are summed up in the CMS report's title, National Health Spending in 2007, Slower Drug Spending Contributes to Lowest Rate of Overall Growth Since 1998. According to CMS, prescription drug cost growth in 2007 was 4.9%, the lowest rate since 1963, and slower than healthcare overall. 2007 was not a one-year blip. Between 03 and 07, the average annual growth rate for prescription medicines dropped by half compared to the 98 to 2002 period. And CMS's most recent 10-year projection reduced expected growth in prescription drug spending by $515 billion, or 14%, compared to 3% for the rest of healthcare. Likewise, CBO reports from 2004 to 2007, drug expenditures grew by an average of just 3.2% per year, slightly less than the rate of growth in overall healthcare spending. Since 1964, IMS Health has found that the U.S. market grew by less than 5% only twice, 2007 and 2008, and it now projects that growth will remain at historically low 4.5% to 5.5% in 2009 and will be 5% or less in each of the next 5 years. At the same time that drug cost growth has slowed sharply, reports like those issued by AARP reach conclusions that conflict with government data and that skew toward finding high price growth. These reports exaggerate drug price trends by failing to reflect the way public policy and the prescription drug market function. Our system is designed to fund the next generation of medical advances through innovator drugs that have a limited time on the market before going generic, and to achieve cost savings through the high use of generics. Large, powerful payers use a variety of tools, such as tiered formularies, to negotiate lower brand prices while driving high use of generics, which now account for about 70% of all prescriptions. We don't believe that each tool used by a purchaser always yields the best possible outcome, and we're encouraged by forward-looking purchasers who are looking at alternatives that make better use of medicines to improve care and control costs. Nonetheless, under the current system, drug costs as a whole are growing slowly, not fast, and consumers use drugs that were once innovator molecules as generics in large volume for many years with little or no return to the innovator. The importance of understanding how the market operates when interpreting pricing data is evident in AARP's most recent report. 8 of the drugs on AARP's list of the top 25 brand drugs are sold as generics. These drugs are counted in AARP's brand price calculation as though patients continue to use them at brand prices, even though brand drugs typically lose nearly all of their sales after going generic. In one example, for a statin, 99% of the utilization for that statin on AARP's list of top used brand drugs is now generic, and the cost per day of therapy has dropped by 58% over 3 years, not reflected in the AARP report. The federal government CPI data on prescription medicines includes a market basket of brand and generics that reflects what consumers actually buy. In the 3 years ended October 2009, drug prices rose by an average of 2.3% per year, compared to 3.8% for all medical care. For the most recent year, the government's measure of drug price growth was 2.7%. The implicit message of reports on brand prices seems to be that the pharmaceutical research companies stand in a uniquely favorable position. In fact, the sector is currently characterized by slow growth, rapid substitution of generics for brand medicines, a projected $90 billion in sales facing generic entry over the next 5 years, and the exceptional challenges inherent in discovering new medicines that safely and effectively treat disease. Through October of this year, 58,000 job cuts have been announced in the industry on top of cuts in 2007 and 2008. Nonetheless, there's reason for optimism that new medicines will continue to improve medical care in the future. Investment in pursuing these objectives, accounted for by the 10% of health spending going to medicines, is repaid to society in longer, healthier, more productive lives. Mr. Chairman, in conclusion, I'll note that the National Economic Council recently published a document titled Strategy for American Innovation, Driving Towards Sustainable Growth and Quality Jobs, which identifies new treatments such as smart anti-cancer therapeutics and personalized medicine as among the 21st century's grand challenges. Achieving these challenges is viewed as important to improving the quality of life and establishing the foundation for industries and jobs of the future. The biopharmaceutical research sector looks forward to its role in bringing these goals to fruition. Again, Mr. Chairman, Ranking Member Deal, thank you for the invitation to testify.
Thank you, Mr. Smith. Ms. Stoll?
Thank you, Chairman, and thank you, Ranking Member Deal, members of the subcommittee. My voice isn't quite as loud as the previous gentleman, but let me I think we've heard a lot of numbers. I'm going to actually give us a little pause from the numbers. I've got a few stats for you, but I also want to paint a picture of what it means to have rising prescription drug spending and prices for consumers. And let me just give you a few numbers, but let me mix in some stories. Increasing access to affordable prescription drug coverage is a top issue for Families USA. We've seen prescription drug spending by consumers more than double in the last 10 years. Now, it's fair to say that that spending is driven by more than just price increases. People are using more drugs, and in many cases that's a good thing. Prescription drug use has increased 72%, while the population is only growing by 11%. That's a pretty good business proposition, I think. Utilization has also changed. That means the kinds of drugs people take has changed. And some of the drugs, the new drugs on the market, the biologics, are more expensive. That's not necessarily a bad thing because many of them are real breakthrough drugs. But we do see statistics that show us that spending on biologic drugs is growing nearly twice as quickly as other traditional chemical drugs. And the third element of why consumers are spending more on drugs, or trying to spend more on drugs, is the cost of prescription drugs, and that's what this hearing is about. And drugs are becoming more expensive. We can go back and forth with stats. I think we should be careful that we understand that reductions in the rate of growth still means you have a rate of growth. And what we've seen is that between 1997 and 2007, retail drug prices, which is what counts for consumers, have increased an average of about 6.9% a year. That's about 2.5 times faster than general consumer inflation. And it seems like that trend might be accelerating. It's really hard to say, and I leave that to Steve. So what does this mean for consumers? If you look at uninsured consumers, uninsured adults, half report that they don't get their prescription drugs filled. They don't get their prescriptions filled, and they don't seek needed refills. And I pause here now to tell you a story, and I'm not going to tell you a story of a dramatic disease, perhaps a rare disease with a dramatic cure. Let me just tell you about a single mom that came to our attention. She has a severe problem with migraines. They're debilitating. Her vision is impaired by them, and she's really left unable to function. And because of her migraines, she misses many days of work and many days with her son. She doesn't have insurance. She does work full-time, and she finally went to a headache specialist, and they went through a couple of different drugs. He had some samples, and after 3 or 4, they found one that works. It's actually like a miracle drug for her. So we do thank the pharmaceutical industry for this breakthrough drug. I'm not going to name it. And the problem is, of course, this brand name drug that provides her tremendous relief from debilitating migraines is very, very expensive, so you know where the story is going. She can get the prescription filled. She gets 6 at a time, and it really takes hundreds of dollars to fill this prescription for 6 pills. So what she has told us is that she saves her pills. And if she gets a headache, a real severe migraine, her doctor said, take it right away, don't wait. But she holds on to those pills because they're so expensive. And she'll go ahead and have a migraine because she doesn't take it early when she should. And the end of the story is what she shared with me, which is she had 1 pill left one month, and she knew it was very expensive. She wouldn't be able to replace it, and her son plays the trumpet, and he had a recital coming. So she held on to that pill, went through 3 severe migraines, missed time at work, missed paychecks, in order to be able to take that pill on the day of the son's recital. She ended up not having a headache that day, but she wanted the insurance. So that's what we're dealing with at the consumer level. If we could bring down the name of that brand drug, it would mean a tremendous difference for this woman who's uninsured. That's uninsured. She's uninsured. Many Americans who have health insurance are still unable to afford prescription drugs. You all know that as premiums go up, people are buying plans with higher deductibles, higher copays. They may have special deductibles and copays just for prescription drugs. So they end up underinsured when it comes to prescription drug coverage. And they, too, make difficult decisions. Either they've paid for coverage because they're underinsured or may not have prescription drug coverage at all. 2 out of 5 of these folks, underinsured, actually go without fulfilling their prescription, filling their prescriptions as well. So a problem of the uninsured and the underinsured. Of course, some folks don't have coverage through their employer. They're in the individual market. I just point out that in the unregulated individual insurance market, consumers are 4 times less likely to have prescription drug coverage at all. Certainly for people with chronic conditions, that's where we see the most impact in terms of high prescription drug spending. A person with a single chronic condition can spend about 36% of their out-of-pocket costs will be for prescription drugs. If it's a person with 2 or more chronic conditions, their out-of-pocket spending for drugs can be 6 times higher than their hospital costs. Now, that's not necessarily a bad thing. I'm just giving you a sense of the impact on consumers. It may be those prescription drugs are keeping them out of the hospital. Certainly, we know that there is a toll in terms of reduced quality of life, reduced productivity, and sometimes it means death to not have access to prescription drugs. It also means that our healthcare system has higher costs long term. I will tell you one more story. It's the story of a child with asthma. Both of this child's parents work full-time. They work full-time, but they have pretty good insurance coverage for themselves. They have no dependent insurance coverage, so their kid is not covered. Their son has asthma. He needs a maintenance drug that costs a couple $100 a month. Because they don't have dependent coverage for their son, and they don't qualify for CHIP, by the way, their son doesn't get the asthma medication on a regular basis. They can't afford it. It's hundreds of bucks a month. These are low-wage working parents. They've tried things like making their 5th grade son wear a mask when he goes to school to help with the maintenance and the management of the asthma. If you've ever tried to send a 5th grade boy off to school with a mask, you know that's probably not going to work too well. So the end of the story is obviously the child without regular asthma medication to maintain and monitor his asthma, keep it under control. He ended up in the emergency room, and he had a very high-cost hospitalization, and it had a very hard financial impact on the family.
I appreciate it. I'm going to ask you to stop now, though, because you're almost 3 minutes. But thank you. Professor Vernon?
Mr. Chairman, and members of the committee, thank you for the invitation to testify today. My name is John Vernon, and I'm a professor in the Department of Health Policy and Management at the University of North Carolina at Chapel Hill, and a faculty research fellow with the National Bureau of Economic Research. In addition to discussing the issue of rising drug prices, I will also discuss the role drug prices play in firm and industry-level R&D investment. The latter is of critical importance because considering drug prices in isolation is not useful. The trade-off between drug prices, industry profits, and innovation is what's relevant. My research on this point is based on unfunded research published in the peer-reviewed economics literature. Regarding the issue of rising drug prices in the U.S., the conclusions drawn by the AARP report are based on flawed methods and thus are misleading. Some of the more serious flaws with the analysis are the AARP report is based on wholesale prices, not retail prices or transaction prices, which are often substantially lower than wholesale prices. And this is because PBMs and insurers negotiate discounts, often steep discounts and rebates with manufacturers. Second, the AARP report is an analysis of branded products only. The burden to U.S. consumers of prescription medications associated with access to prescription drugs should also consider generic drugs, which in the U.S. have among the lowest prices in the world and the highest utilization rate. For example, approximately 70% of all prescription drugs dispensed are generic drugs. So we have both the highest utilization rate and also the lowest prices. Much of this credit goes, of course, to the 1984 Waxman-Hatch Act, which did a nice job of balancing innovation with generic competition. And three, in the AARP report, 10 of the top 25 branded pharmaceuticals in their study actually have generic versions currently on the market. Mandatory generic substitution laws in most states implies that the lower cost generic versions of these 10 branded drugs are dispensed to consumers, not the branded versions. In my opinion, and based on my experience as both an academic journal editor and peer reviewer for academic journals, this study as it stands does not meet the peer review standard for academic publication, and that's the hallmark of academic research. A better measure, in my opinion, of drug price trends in the U.S., one that is based on retail prices, not wholesale prices, and which also captures the cost savings from generic competition and substitution, is the Prescription Drug Consumer Price Index reported by the U.S. Bureau of Labor Statistics. The BLS prescription drug inflation rate for 2009 is approximately 3%, or roughly 1/3 of the 9% inflation rate reported by the AARP. Moreover, the change in drug price inflation was approximately half that, in the most recent year, of the change in the inflation rate for non-prescription drugs and medical supplies. This suggests the small increase in prescription drug prices may reflect broader health sector market dynamics and not an isolated increase in prescription drug prices. As previously mentioned, a consideration of prescription drug prices in isolation is an incomplete and misleading exercise. What must be considered are the costs and the benefits of higher or lower prescription drug prices, and specifically the economic trade-off between access to existing medicines and access to future, yet to be discovered medicines. The expected returns on individual R&D projects are directly related to expected pharmaceutical prices and profitability. Price controls or indirect price controls via such mechanisms as reimportation or technology assessment rationing lower expected net returns for firm shareholders. The result will be a decline in the rate of pharmaceutical innovation, fewer new drugs will be developed, and it will take a longer time to find cures for many diseases. Unlike the benefits of a price control policy, which clearly would be to improve access for today's consumers and seniors, explicit or implicit price controls which will produce immediate and observable cost savings through lower drug prices, the cost of a price control policy in terms of foregone innovation is much more difficult to appreciate and quantify. What might we have discovered? How much more quickly would we have found a cure for Alzheimer's disease? These are very nebulous and difficult to appreciate and certainly to quantify, but that does not justify not considering these very important costs. A full economic analysis considers both the costs and benefits of any policy or healthcare reform. The sensitivity of R&D spending to pharmaceutical prices and profits has been studied with a variety of different research methods, including standard retrospective statistical analyses of industry and firm-level data, prospective simulation analyses, and financial event studies. The research findings have been strikingly consistent and robust. I will summarize the results from two recent studies published in the economics literature that I authored by myself and with co-authors. The first study utilized publicly available firm-level financial data and exploited observable differences in the U.S. and non-U.S. pharmaceutical profit margins. Outside the U.S., most countries have some form of price regulation, explicit or implicit. Using established economic models and statistical techniques, we estimated that a new policy that reduces pharmaceutical profit margins in the U.S. to non-U.S. levels will cause firm R&D spending to decline by between 25% and 35%, all things considered. A policy that regulates prices in the U.S., for example, reimportation from foreign markets with forced sales clauses, those foreign markets, of course, having price regulation, will theoretically have this effect on U.S. profit margins. The second study adopted a slightly different approach and utilized publicly available industry-level data to study the direct link between U.S. drug prices and industry-level R&D spending. In this study, we estimated that for every 10% reduction in U.S. prices, industry R&D spending will decline by approximately 6%. We call that an elasticity estimate of R&D with respect to real drug prices in the U.S. This finding is also consistent with an earlier study by Harvard economist F.M. Shara. In sum, the empirical evidence suggests that firm R&D spending is very sensitive to pharmaceutical prices and profits, as economic theory would predict, and the empirical literature supports. The key point is that the benefits associated with lower drug prices, and it cannot be argued that there would be benefits, improved access to medicines that are currently on the market and available, would unequivocally come at a cost, lower levels of R&D investment, and a reduced rate of pharmaceutical innovation. It is critical that these costs be balanced carefully against the benefits of associated regulation, explicitly or implicitly, that regulates drug prices. This is particularly true in light of the recent evidence on the significant contributions of pharmaceutical and medical R&D to human health and life expectancies in the U.S. Research that suggests the U.S. is currently underinvesting in medical and pharmaceutical research based upon the benefits that we enjoy in America as a result of improved quality of life and extended life expectancies. Thank you very much.
Thank you, Professor. Ms. Kramer.
Thank you, Mr. Chairman and members of the Health Subcommittee. I am Bonnie Kramer. I'm chairman of AARP's All-Volunteer Board of Directors. And on behalf of our 40 million members, thank you for including AARP in this discussion of brand name prescription drug prices. As you know, AARP is deeply committed to making prescription drugs affordable for our members and for all Americans. And whether we're ready to admit it tonight or not, the United States is aging at an unprecedented rate. Starting on January 1st, 2011, 10,000 people will turn age 65 every day, and this will continue for the next 20 years. When combined with the rapidly escalating brand name prescription drug prices and the fact that older Americans use prescription drugs more than any other segment of the population, it seems evident that many Americans will soon find themselves unable to access the drugs they need at a price they can afford, and that, we believe, is not acceptable. As part of these efforts, AARP's Public Policy Institute, working with Dr. Schandelmeyer, has been reporting on manufacturer price changes for prescription drugs since 2004. We have done our prescription drug watchdog report. Our latest report found, as you have heard, that average manufacturer prices for widely used brand name and specialty prescription drugs continued to increase substantially between October of 2008 and September of 2009, rising by 9.3% and 10.3% respectively. Now, it's been twice said that 70% of all prescription drugs are generic, but you need to know that 76% of all spending is for brand drugs. Rising prescription drug prices are a source of concern for many of our members, and it can impact their health. The inability to afford needed prescription drugs has been shown to negatively impact patient adherence to drug regimens. Many consumers report that they have not filled prescriptions, they skip doses, they cut pills in half as a result of high prescription prices. These are stories that we hear from our members every day. This type of behavior, in turn, can lead to more expensive health care needs in the future. Problems paying for prescription drugs are more common among those taking a larger number of medications, such as older adults. Approximately 20 million AARP members are over the age of 65 and eligible for Medicare. The Part D benefit, which AARP fought very hard to enact, provides much-needed prescription drug coverage for Medicare beneficiaries. But unfortunately, the Part D benefit currently contains a donut hole, where the beneficiary must shoulder the entire cost of the drug as well as continuing to pay their premiums. More than 3 million Americans are at risk of falling into the donut hole each year and feeling firsthand the impact of rising prescription drug prices. Unfortunately, because the donut hole is indexed to prescription drug spending, the donut hole is growing larger each year. As a result, more people will fall into the donut hole in the future. And that is why we at AARP have made closing the donut hole one of our top priorities this year as part of health care reform. But price increases also impact Medicare Part D enrollees. It impacts their cost sharing for their brand name prescription drugs. A recent AARP Public Policy Institute analysis of most national Part D plans shows that in 2010, more plans will require co-payments of close to $100 per drug for certain brand name drugs. Other plans will use co-insurance or a percentage of the drug's cost for brand name medicines as high as 65% of the drug's cost. We are greatly concerned about the future of Medicare's Part D and B, which are financed through premiums and general revenues. As prescription drug prices continue to increase, spending will grow correspondingly, which means that all Medicare beneficiaries, as well as all taxpayers, will be required to pay more in order to keep the program solvent. Now, AARP was pleased to endorse the Affordable Health Care for America's Act, House H.R. 3962, that recently passed the House of Representatives. For years, AARP has been fighting to make sure that our members and all Americans have access to affordable health care coverage. Key to our endorsement was provisions that would close the donut hole, which the House bill would begin to do next year and would fully close the donut hole by 2019. We also support the House Health Bill's provisions that would grant the Secretary of Health and Human Services the authority to negotiate on behalf of Medicare beneficiaries. We've also supported provisions that would promote medication therapy management services. So, Mr. Chairman, thank you for your continuing efforts to improve the nation's health care system. At AARP, we look forward to continuing to work with you to ensure that prescription drugs remain affordable for our members, for all Americans, and for all health care payers. I appreciate the opportunity to be with you today, and I look forward to your questions.
Thank you, Ms. Kramer. We're going to have questions now from the members, and I'm going to start with myself. I'm going to try to get in two topics here with you, Mr. Schondelmeyer. Well, let's say this. We passed, I'll say this. When we pass or when we finalize the health care reform legislation, it'll mark the second time in 6 years that Congress has passed important legislation affecting the prescription drug market. In 2003, we passed the legislation creating Part D, and you've analyzed drug prices before and after Part D went into effect. So what happened in the months before Part D went into effect, and are we seeing the same thing happening now with this health care reform legislation?
Thank you for the question, Mr. Chairman. I would respond by providing observation and pointing you to Figure 5 in the testimony that I prepared. And basically it shows in the time period prior to Medicare Part D being first passed and then later enacted. Remember, there was a delay time between when it was passed and when Part D actually got implemented, 2003 to 2006. Prescription drug prices did increase during that time period substantially. They leveled out if 6+% is leveling out in terms of price increases for a brief period. And then after the last fall's elections in November, when it appeared that health care reform might be a topic that comes into play again, we saw an increase. Now, this is not a cause and effect relationship, but if one looks at the graphs, it's pretty apparent that there is an increase.
So you don't think it's a coincidence, obviously?
I don't think it is. Again, there are multiple factors that affected drug companies' choice to raise their prices, but I think this certainly is one that weighs in. The mentality that may be going into effect is if R&D is as important to them as they say it is, and I believe it is. And we as a society want the innovation and the R&D and other factors. And so if they rationalize, well, if they're going to start controlling or affecting my prices by having a more effective market in some way, and I have a less controlled market right now, I'm going to push the price as much as I can so when they start squeezing, I'm at a higher point on the mountain when they're trying to bump me down a little bit. And so it makes sense to do that.
All right, Mr. Smith, I have to ask, let you have an opportunity to respond, but I have to go back to him, so if you could just spend about a minute or so, I appreciate
Responding
it.
to the last point. Mr. Chairman, thank you for the opportunity to respond. Unlike Dr. Schandelmeyer, I'm not going to speculate about motives, as I made clear in my statement. I can't discuss pricing decisions and so forth. But what I can say is that, number one, the Consumer Price Index, as has already been discussed, has, for the year ended with the period that AARP looked at, was up about 2.7%. I can also tell you that the prices are negotiated with purchasers who are large, sophisticated, powerful, have many tools. My guess would be, and I have to underline guess here, sir, my guess would be that if a company went to one of these purchasers and said, we need you to pay us more because health reform is coming, they would be laughed out of the room.
Okay. Now, you mentioned, I'm going back to you, Dr. Schonemeyer. At some point, I don't know if it was in your testimony or in your written statement, you mentioned that the wholesale acquisition cost does not include discounts or rebates that are provided by the manufacturers to wholesalers. And when these discounts are factored in, it has the effect of lowering the price paid. And you stated in your footnotes that there is no consistent, comprehensive, and publicly reported data sources for this discount and rebate information. That gets to the issue of transparency, and that's my question. How would better drug pricing transparency help patients? And, I mean, what would you suggest in terms of trying to create more transparency?
Well, first, if we're really talking about an economic market and making wise decisions, we need to avoid, and I'll use the technical term, asymmetric markets, where the seller knows a whole lot more about their product than the buyer. Asymmetric markets were defined by Nobel economists who described the market for lemons or used cars. In a sense, drug companies, thankfully, know a lot more about our drug products than we do, but that gives them extreme economic power in the marketplace. Rebates and discounts are out there, and they may lower the actual price, but they don't lower the rate of increase unless the rebates and discounts are increasing as a proportion.
But what do you suggest in terms of, you know, what we could do on transparency?
Well, one, for example, in Medicare Part D, you could require the Part D plans to disclose the amount of rebates that they get. Apparently, the committee in the past couple of years has done studies of the Part D plans. The Part D plans have reported that they get rebates that are on about 10 to 14% of the drugs, and they may get some rebates, but they've admitted they don't pass them on to the consumer. And apparently, it doesn't lower the premiums, because this last year, Part D premiums went up 11%, and last year they went up 17%. So the only two places I can see that rebates can benefit either the Medicare beneficiary or the taxpayer would be in lower premiums or lower prescription prices, and they don't appear to show up in either of those. So I don't know where they went.
Thank you. Mr. Deal?
Mr. Kramer, I'm told that 52% of AARP's annual revenues come from royalty fees from insurance company profits, and less than 20% of it comes from your membership dues. In 2008, I'm told that AARP generated $414 million in royalty fees from United Healthcare Corporation. Could you tell me what percentage of those revenues came from the sale of AARP Medicare supplement insurance plans that were offered by United Healthcare Corporation?
I don't have that figure with me. I will be glad to get it for you. Those numbers you cited are approximately correct. But let me just say that AARP is not an insurance company. We contract with United Healthcare to provide insurance to our members, and we provide market-changing policies. We make sure that our members have the best policies that we can have under state and federal law. Providing insurance to AARP members is the reason AARP was formed over 50 years ago, when our founder, the private market was not serving older people, and it was not serving retired teachers. Our founder was a retired teacher. It is the beginning of our organization. But I do want to say one other thing, which I've heard said in Congress numerous times, especially over the weekend. I am the chairman of the all-volunteer board. We had over 15 to 20 meetings on health care reform, detailed meetings. Not once did the AARP board talk about the money we might make on our insurance products or the money we would lose. We would gladly forego all of that.
You will get us the information to the question that I've asked.
I will
Is that
get
right?
the information on what portion is related to Medicare supplement.
When you announced your endorsement of the health care reform plan, you cited the fact that pre-existing conditions would be excluded under that legislation. And yet the supplemental plan that you sell has a 6-month waiting period. And the way the legislation has been crafted is that your supplemental insurance plan will still continue to have the opportunity for a 6-month waiting period as an exclusionary period. Was that a condition that was negotiated with the White House as a condition for endorsement?
It was not a condition negotiated with the White House, and AARP has been on record for a long time of supporting guaranteed issue for Medicare beneficiaries.
But you think it's fair for your supplemental plan to have a pre-existing condition exclusion, whereas other plans in the basic coverage would not?
That's something that we can look at. It was not a deal with anyone, and certainly we do support guaranteed issue.
All right. Let me ask the panel, and this would be something that any of you could address. We are concerned here about trying to figure out how to get consumers in the United States the best value for the dollar they're paying for prescription drugs. Do you believe that U.S. consumers are paying a disproportionate share of R&D cost compared with the rest of the consumers in the world? Anyone want to take a shot?
Mr. Deal, I'll note that other countries clearly underfund their R&D. They're not paying their share of R&D, particularly other developed countries. And I believe that the result is less R&D occurs and fewer new drugs are discovered, and that's a loss to Americans as well as people in their own country.
But aren't you shifting those costs to American consumers?
Yeah, Mr. Deal, I can't speculate about how pricing might occur cross-nationally.
Dr. Charlton, you have an observation?
Well, again, in terms of the individual decisions of companies and specific decisions, it's hard to say. But if you look at the market, and as described by Mr. Smith, if other countries are underfunding and we're paying a substantially higher price and we are getting R&D, which we value, we are overpaying. We are essentially letting other countries be free riders on the R&D that we're paying.
Very quickly, I want to...
So what we do with that is a different issue. I think we probably need to look for a new model of funding R&D rather than funding 10 years from now the new drugs based on the high price of drugs today to the degree that some people can't afford them. I'm not sure that model's working today.
I want to go quickly to your analysis that brand name drugs increased 9.3% in your study. Specialties, which you said were primarily biologics, increased by 10.3%. Isn't it logical that in the brand names where their patents will expire, that those prices will drop in the future, whereas if we grant, in addition to patent protection, some 12 or more years of market exclusivity on biologics, that you're going to see that increase in the biologic arena continue to be an escalation?
I don't recall more than 2 or 3 brand name drugs that I've ever seen drop their price, and those were under political pressure.
But the point is...
Well, it was pointed out that some of the drugs in our index actually have generic competitors in the market, and yet those brand name drugs keep going up in price, sir.
Yes, but if you build in a 12-year exclusivity period that prolongs any ability for a follow-on biologic, don't we compound that problem?
Not necessarily. I think one has to do a reasoned assessment of what is an appropriate time for recovering that innovation cost and R&D cost. I think if you make it too short, you can stifle innovation. I think if you make it too long, you can stifle innovation. If you make it too long, you allow companies to rely on cash cows, which is much of what we see now, products they just keep hanging on to and riding, and finding what they find is Nexium instead of Prilosec, which isn't a new drug, it's just the right-handed version. And we have a number of those, or Ambien CR instead of Ambien, which isn't a new drug, it's just a manipulation. So if we let the period be too long, it can be just as damaging as too short. And I think the period that's currently in the bills at 12 years is on the long side.
Chairman Waxman.
We have heard the estimate that the amount of prescription drugs over a 10-year period has increased 72%. Well, that's a big increase in people using drugs, or at least a number of prescriptions. So the market for drugs has increased over the last 10 years. Dr. Schnondelmeyer, you say that the drugs in the past year have increased on an average 9%. Is that a correct statement?
It is, but we need to parse out increased expenditures from increased prices.
Okay.
Expenditures go up because of increased utilization and increased price and increased changes in the mix. The price index I report with AARP is a pure price index, price only. The actual utilization of prescription drugs in the last year to 2 years has flattened out or even decreased slightly in some therapeutic markets, yet the prices keep going up. And the private payers, the large PBMs, report price increases similar to the 5.4% that we show for our aggregate composite index, rather than the 2.7% that CPI has. And I would point out, Dr. Vernon commented that my study only looked at brand name drugs. Apparently he's only read the New York Times version of my study, because if you read the full study, you'll see that we do look at brand names and at specialties and generics, and we calculate a composite index.
So you have a composite index of all of those drugs. Let's parse them out. Are brand name drugs where the drug manufacturer still holds a patent, which means it has a monopoly, going up faster in increase for the prices of those drugs than a generic drug competing with a brand name drug?
In our index, brand name drugs can be either patented single source products, or it can be brand name drugs, the originator, the original NDA holder. They may not have discovered the drug at all. They may have licensed it in. But the original NDA holder, even after their drug is off patent, may still be in our index in some cases, because those products are still on the market and the prices are going up. So we track those prices, and then we track generics, and they're going in opposite directions, 9.3% up and 8.7% down for generics.
So where there is competition from generics, the generics are going down in price, and where there's no competition, the price of drugs is increasing?
It's increasing, and even the brand name, when it has generic competition, doesn't enter into the economic competition by lowering its price.
And
it may lose volume, but it doesn't lower its price.
And this seems to be happening whether the economy is booming or in a recession, whether the number of uninsured is going up or down. It doesn't make any difference.
It doesn't appear to have done so over the last decade, and we've had both of those periods, some booms and some busts.
Now, over the last decade, I assume there have been increases every year. Are there 2 years? Are they pretty level, or is this 9% higher than the general increase over the last 10 years, let's say.
The rate of increase is the highest, at least from the data I've done with AARP, I've seen in the last 7 years. And when I look at other indices and other similar data going back even 15 years or more, this is the highest level we've been at for quite some time.
Now, let me go back to the question Mr. Deal asked you. These specialty drugs, which are really biologic, for the most part, the biologic drugs, these are the new breakthrough drugs, but they're very expensive drugs, aren't they?
Yes, these on average cost, thousands to tens of thousands of dollars, if not in some cases hundreds of thousands of dollars per year.
And for the most part, these drugs have no competition.
They do not have competition directly in an economic sense.
In an economic sense, what does that mean as opposed to
in a sense that would lower the price? The drug companies there may be 2 drugs for multiple sclerosis, and the drug companies may very vehemently compete through advertising and through calls on the doctors that treat those patients, but it hasn't had an effect on the price or an appreciable effect on the price.
Is that because one is not substitutable for the other?
Substitution has been a major mechanism to bring about economic decline of generic prices in the regular drug market, and that is not available for the biological products. There is no equivalent of an ANDA for a biological license application.
Now, there's a bill that promises the developer of a generic drug 12 years of exclusivity, and then there can be competition, but that competition may not be a substitutable competitor. So we're not guaranteed a reduction in prices even after 12 years, isn't that right?
That's probably correct. It depends on the terms of how that bill would bring about or allow other products in the marketplace. What you need is an equivalent of the FDA therapeutic equivalence evaluation for normal pharmaceuticals to be developed for the biological market.
So they claim they have to have a 12-year exclusivity because competition is going to drive down the price of that drug so dramatically. But in effect, they're going to have much longer than 12 years to be recouping a huge amount for their drug. So we're really talking about not just a 12-year period, but a much longer period of time in which this drug will have market dominance. Isn't that correct?
That's quite likely, and in addition, they're likely to come out with alternate dosage forms and remarket the drug in a different dosage form that has a new patent, has a new exclusivity.
Yeah, we have evergreening in the bill that passed the House and the Senate, which means there's no end to the monopoly control they're going to have over these biologic drugs. And monopoly control, is it fair to say, in your experience, means higher prices?
Yes.
Okay. Thank you, Mr. Chairman.
Thank you, Chairman Waxman. Gentleman from Illinois, Mr. Schimpers.
Thank you, Mr. Chairman. I think we're developing more questions and less through this hearing, but that's a positive thing, I think. Ms. Stoll, I would just request that if you have these constituent stories, one, I would just ask if they have gone to their member of Congress to ask for assistance. We deal with folks in many of these similar situations. And I would also highlight the fact that if that member is not willing, you provide those names to my office, we will try to intervene, because I know the pharmaceutical companies have options in which they can provide discounted or low cost or drugs for free, and we use those operations frequently in my congressional service. I don't have time, I have limited time, but I just want to throw that out as an option for these stories that you've given us today. To Mr. Smith, we've heard a lot about, quote unquote, the deal between Pharma and the White House. Can you explain what that deal is?
Congressman, what I can do is, I wasn't asked to come and explain the deal today. I can try to give you sort of
I've been told it's pretty well public knowledge.
Yeah. I mean, there's been public announcements by the White House. I believe AARP attended a public announcement of the initiative at the White House. There have been public announcements from the Finance Committee. So our board concluded that in line with its longstanding support for moving forward in health reform that was mentioned by the chairman in his opening comments, that we wanted to support moving forward.
Okay, well, I'm actually looking for more of the specifics. So, do you know if the Senate Health Bill reform reflects, quote unquote, the negotiations?
The Senate bill is so much in flux, it would be hard for me to make an assessment.
I would like for y'all, these are questions that I'd like to get answered, so I would hope that you would. My concern is H.R. 3962.
Yeah.
There's negotiations behind closed doors, and I want to know what those have negotiated, which then turns me to AARP. Ms. Kramer, you said that, Mr. Chairman, I'd like the consolidated financial statements from December 31st, 2008, 2007, and the IRS Form 990 for 2008 submitted for the record with your approval.
Can I just take a look at it?
Yeah,
Because I'm not sure I know what you're talking about.
It'll be followed up with these questions. Ms. Kramer, you stated that you all don't have an insurance plan, but on the 990, you list one. And on the IRS Form 990, it says the AARP insurance plan. So my question is, do you have an insurance plan or do you not?
What I said is that we contract with United and other health insurers to provide insurance to our members. We also contract with Aetna for the 50 to 64-year-old product. We contract with Genworth to provide long-term care insurance to our members. We even provide homeowners insurance and car insurance to our members through contracted agents.
Reclaiming my time, what it says on the IRS Form 990, at the direction of third-party insurance carriers, the plan pays AARP Incorporated a portion of the total premiums collected for the use of its intellectual property, which is reported as royalties in the consolidated statements of activities. Is it correct?
It's correct that we make royalties off the sale of insurance.
Reclaiming my time, so you're acting as a grantor trust. And in essence, when the profits are made through the selling of this insurance, then that then goes back to you all. In fact, AARP benefits from selling the most costly insurance because that portion then goes to operate AARP at a major profit. Is that correct?
It goes back to support the advocacy and education efforts of AARP, yes.
And I would say that in about current operations, it is about $653 million in annual revenue based upon this portion, which was stated by Mr. Deal as, what, 3/4 of the operating budget?
The budget is about $1.3 billion, but that amount is approximately correct, yes.
Yeah, 52% of your fees of our annual revenues come from these insurance fees.
Correct.
And 20% of AARP's annual revenues come from membership dues. That's correct.
About 24%.
Could you operate
dues.
without this $653 million in annual revenue?
I've already answered that question. We were founded on providing insurance
just
with
answer
contract.
Can you operate currently without this revenue that you
We
all
have
receive based upon selling insurance? Yes or no?
We have never looked at that. I don't know how to answer that.
So if you're without $653 million, you don't know if your operations would change?
Well, obviously it would change if
Thank
it's
you very much. I yield back.
52% of the revenues.
The gentleman from Illinois has asked unanimous consent to enter into the record AARP's consolidated financial statements from December 31st to 2008 and 2007. Without objection, so ordered. Next is the gentlewoman from California, Ms. Eshoo.
Thank you, Mr. Chairman. I can't help but observe the following. It's always interesting around here when advocacy organizations endorse legislation. I remember not that many years ago when my friends on the other side of the aisle had their arms wrapped around AARP, hugging them so tight because they were supporting, quote, Medicare Part D and all that came with it. Today, they're attacking the hell out of AARP because they have endorsed this side of the aisle's health care, universal health plan for the American people. So I guess, as Kurt Vonnegut said, and so it goes. But I can't help but make the observation, and I guess that's the way it goes around here. Thank you for each one of you for coming to testify. I think if we could stay away from good guys and bad guys, we would just be much better off. What we need to do is to scratch below the surface and see what it is that is causing the prices to be what they are, which we all know is a burden to the American people and especially older citizens in our country. I believe in research and development. I believe in science. It's at the heart of all of the work that I've done here in Congress. Some say that favors some and doesn't help others. I think that that's a source of pride to our country, and I want to keep that and innovation alive. But I also think that we can do a much better job with what the costs are. Now, the House has already passed the health care reform legislation, and hopefully the Senate is going to do the same. As we go to conference, I think it's important that we get some perspective on how provisions in these bills will help to reduce drug costs. The House bill has numerous provisions to protect taxpayers and all citizens from increasing drug prices. It increases Medicaid rebates. It provides insurance with drug coverage for 36 million citizens. It requires pharmaceutical manufacturers to give a 50% rebate for drugs in the donut hole. It closes the Part D donut hole, which the other side all created together with AARP and thought it was terrific then. Now it's costly, and we're being attacked for what it costs to plow back and fill this hole. But fill this hole we must do because of what it's doing to senior citizens. It allows the Secretary to negotiate for lower Part D drug costs. Now, the Senate bill contains some of these provisions, but not all. It doesn't close the Part D donut hole. It doesn't allow the Secretary to negotiate, and it doesn't create new Part D rebates. So to Dr. Schondelmeyer, let me ask you generally, do you believe the provisions in the House bill or the Senate bill will do a better job of protecting seniors and taxpayers from rising drug prices? I mean, it's a softball question, but I still think we need to get the answer on the record.
Well, I believe there are many useful provisions in the House bill that would assist in that goal. It's as with many tools that we have in society, though, it all depends on how they're implemented.
And how they're implemented. Ms. Kramer, do you agree?
We have strongly supported the House bill. We are working every day in the Senate to try to get the donut hole closed completely.
Good. Let me ask about a specific provision in both bills. It's a provision that requires manufacturers to provide a 50% discount on brand name drugs in the donut hole. My understanding is that this offer was made by the drug manufacturers as part of their negotiations with the Senate and the White House. Now, this is not a bad provision. We have it in the House bill as well. But it seems to me that it has some problems. What manufacturers give, which in this case is a 50% discount, manufacturers can take away by increasing the base price of their drugs. So to Dr. Schondelmeyer, am I understanding this correctly? As manufacturers increase prices, can they also wipe out many of the benefits of this 50% discount?
I believe they can, and they have the market power to do so. The current price increases for this year may have come close to wiping out the whole $80 billion over the next 10 years.
Now, let me ask the panel, I mean, whomever would like to step up and answer this, what do you think is the best way to protect us from what I just described?
Congresswoman, thank you for the opportunity to answer.
Yeah, keep it short.
I will.
10 seconds.
Certainly. Absolutely. Part D, as you know, has come in at a much lower cost than expected. That's because of the competition and the negotiation that goes on. Contrary to Dr. Schondelmeyer's point, of course, the 50% discount that will be provided in the coverage gap is a 50% discount off of the negotiated price. So I think that there is a real benefit to seniors there.
Dr. Schondelmeyer, do you want to respond to that?
Yeah, you tell me how much discount you want, and I'll tell you what the price is. That's kind of the way the market works today. Yes, there is some negotiation, but it's at the margins. It's mostly about retail prices, not about meaning the retail margin and the retail dispensing fees. It's not much about brand name, single-source drug product negotiation. I work with major buyers in the marketplace, the major autos, with my own university, and we don't get discounts on those brand name prices.
Congresswoman, can I get 5 seconds of your time, please?
You have to ask the chairman, not me.
Yes, and then we're going to finish.
I'll simply note that, again, contrary to Dr. Schondelmeyer's assertions, if you look in the Medicare trustees report, they'll note that while generics don't carry rebates, I believe their phrasing is many brand name drugs carry rebates, often 20 to 30%.
And the generics are priced so low that a rebate on the brand name still doesn't get the brand name close to the generic price.
Well, Mr. Chairman, I think this whole issue of the increase of the prices says to us that we need to get socks on this octopus, because if the rate continues to rise as much as it already has, and the predictions of the industry itself underscoring that, then by the time the entire national plan for universal health care takes place, then that a whole new floor is established. And this is about bringing prices down across the board so that we have affordability for people. So I think that we've got to press hard, look hard on a provision that will be placed in the bill that, you know what I'd be willing to do is to say that by such and such a date, this is what you have to do. And a hammer comes down by that year. If you haven't, then the prices are just going to drop. Thank you.
Thank you, and I apologize for turning the clock off. I wanted to make sure Mr. Gingrich got his 8 minutes since he didn't have an opening. I recognize the gentleman from Georgia.
Mr. Chairman, thank you very much, and thank you for allowing me the extra time for questions. I'm going to direct all my questions to AARP and to Mrs. Kramer. Ms. Kramer, my first question, to your knowledge, has AARP been contacted by the Justice Department concerning alleged large kickbacks, well, actually you call them royalties, that you receive from insurance companies for your Medigap plans, a matter that, as you know, Chairman Rangel suggested he would be referring to the Justice Department during the Rules Committee hearing on H.R. 3962 last month?
To my knowledge today, no.
Well, if you do hear of that and have that information that the Justice Department is looking into that, would you be willing to let the committee know that you have been informed by the Justice Department?
Surely.
Good, thank you. The second question, today roughly 1 million customers purchase Medicare Advantage plans, roughly 8% of the market, and 2.8 million Medigap plans representing roughly 30% of the Medigap market, bearing the AARP logo. Under the House and Senate health reform bills, Medicare Advantage plans would be cut, again, I'm sure you know this, by as much as $160 billion. Yet Medigap plans do not endure these same cuts. Under the House and Senate bills, Medicare Advantage plans would be forced to pay 85% of revenues received for medical claims. Yet Medigap would only be subject excuse me, to pay 65% of its revenues on claims. Are you aware that Medigap plans are not held to the same 85% standard as all other insurance products, but Medicare and non-Medicare policies under the House or the Senate health reform bills? Yes or no?
No, I was not aware of that.
Would AARP be willing to forego this sweetheart exemption that clearly favors AARP and their Medigap plans in order to help reduce the cost of health care for its members who receive their insurance from the Medicare program?
I can't answer that on Medigap. I can say that on Medicare Advantage, we have supported the reduction. We also contract for Medicare Advantage plans. And
reclaim my time. I don't understand how you could say that you're not sure or that you wouldn't support
I'm
that.
just telling you we have not discussed that, and so I just can't answer that today. I don't have that information. We haven't even discussed that among the board.
Well, Ms. Kramer, in the interest of your 40 million AARP beneficiaries, including myself, don't you think it would be your responsibility as a board, all volunteer board, to discuss things like
As
this?
I indicated, I would be glad to get back with you on that.
Well, I'm glad to hear that. My third question, Representative Deal mentioned Medigap plans would not be subject to pre-existing condition coverage like every other insurance product sold in this country if H.R. 3962 were to become law. Considering that an AARP member in New York has actually brought suit against you in January on this very issue, would you be willing to tell this committee today that AARP would like that provision changed in order to ensure that your members who currently receive the health care from the Medicare program would not be forced to purchase a Medigap plan with a pre-existing condition?
As I indicated previously, we have for years supported guaranteed issue of Medicare policies.
Well, then your answer is yes, you would be.
I believe I answered that we would discuss that within our board. I can't answer that today, but we do support guaranteed issue.
Well, I certainly would hope so, and I thank you for that response. The next question. The House and the Senate health reform bills would cut Medicare Advantage plans by as much as $160 billion. Cuts at CBO figures will force 3 million seniors to lose that coverage and then revert to the traditional Medicare, and 8 million more if insurance companies are forced to stop selling altogether by the health choices czar if he or she chooses. As we all know, Medicare Advantage plans offer seniors benefits that traditional Medicare doesn't. Services like dental, hearing, and vision, just to name a few. Therefore, seniors will be forced to purchase a Medigap policy to make up for those lost services. Policies for which AARP has a significant market share and would stand to gain substantially. I see a significant conflict of interest in your support of legislation that would allow you, AARP, to gain customers and therefore further royalties from a product in which you have a significant market share, namely Medigap plans, because seniors are being forced off of Medicare Advantage plans, plans for which AARP products does not have a particular market advantage, as I think you said in your testimony. In light of these concerns, would AARP be willing today to rescind its support of H.R. 3962, the Pelosi Health Reform Act, if changes to bring Medigap policies in line with all other insurance products are not made? Yes or no?
We have supported the House bill. We've also supported the cuts to the Medicare Advantage. We also contract for Medicare Advantage, and we would willingly forego any revenue to get those changes in place to get affordable health care for our members.
Let me ask you one last question in my remaining time. I have seen recent reports that AARP supports the Senate Democratic version of health care reform. One of the ways in which the Senate health reform bill pays for the reforms it seeks is through a payroll tax on all those making $250,000 or more each year. Unfortunately, this payroll tax is not pegged for inflation, meaning that it will negatively impact your members, including myself, age 50 to 64 today, and over time cause those making well below $250,000 a year to pay this additional payroll tax of 0.5%, increasing the Medicare payroll tax from 2.9 to 3.4. Does AARP support the use of a payroll tax to pay for health care reform?
Senator, we have not endorsed the Senate bill. We are working to get the age rating provision in the Senate bill. It does not meet our what we would like to have. It is 3-1. We do not support that. And the Senate bill does not fully close the donut hole, which is our top priority.
Ms. Kramer, reclaim my time. Are you saying that you do not support the version of health care reform in the Senate bill that raises a payroll tax 0.5%?
I'm saying that we have not endorsed the Senate bill as of this time.
Again, I want to ask you specifically a yes or no question. As the chairman of the board of AARP, do you or do you not support increasing the payroll tax 0.5% to help pay for health care reform, whether that's in the Senate version, the House version, or in a conference report that comes back to us later in the year or the first?
We believe that revenues will have to be raised to provide all Americans affordable health care.
Last point in my remaining few seconds, would you support a change in the final bill indexing this tax for inflation if indeed that increased payroll tax is in there?
We have not discussed that. I cannot speak to that today.
Well, I'm disappointed that you can't speak to that as being a responsible board member, volunteer board member, advocating on behalf of 40 million seniors to try to keep costs down, because clearly this is not a partisan question. This is just an issue of doing the responsible thing on behalf of your membership. Mr. Chairman, with that, thank you for the additional time, and I'll yield back.
Thank you, Mr. Gingrey. Next is the gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. And Ms. Kramer, I appreciate ARP's support for the House passed bill that doesn't have the payroll taxes the Senate does. But Dr. Schoenemeyer, you conducted the study that found the brand name drug prices have increased 9% in the last year. We heard a lot of criticism of that study by Dr. Vernon and Mr. Smith in your testimony. How do you respond to that criticism? Does your study present a true picture of what is going on with prescription drug prices?
I believe it does. First of all, the price data we used are prices actually reported by the drug companies. And I'd ask, if they're so concerned about those prices not being accurate, why are they reporting inaccurate prices in the market and to the price databases? Second, the Consumer Price Index is a very useful measure, but it measures a market aggregate only for the retail market. The CPI doesn't even include most specialty drugs in the marketplace. And the CPI, and by the way, I would correct another number people have thrown around, that drugs are 10% of our health care expenditures. That's retail outpatient prescription drugs are 10%. Drugs in all settings, in hospitals, in physicians' offices, and every other setting, are about 17% of the total national health expenditures, and yet we keep fooling ourselves thinking they're only 10%. So I think our market basket reflects the full spectrum of drugs in the marketplace, in the places where they're used, and it's based on prices reported by the manufacturers.
They also ask that your study does not take in the discounts and rebates provided by drug manufacturers into account. Does that skew the results?
I have offered opinions that I don't think it appreciably skews the results, because I don't see in the marketplace where consumers get the benefit of either those rebates or discounts. I have never met a consumer, nor have I myself, directly received a rebate from a drug company, and I've never met a consumer who says they have. Supposedly, the Medicare Part D plans do negotiate rebates, and it's supposed to either lower the premiums or the drug product price, but when the Office of the Inspector General for HHS evaluated Medicaid prices versus the Medicare prices back in 2007, he found that for brand name drugs, the Medicaid price was actually on average 0.6% lower than the Medicare prices before rebates were taken into account. When rebates under Medicaid were taken into account, it would have reduced the price by about 30%, but those rebates don't exist and aren't paid to the government on the Medicare side. So they can have an impact, but the way they're implemented under Medicare Part D, they don't appear to get passed to the consumer or the taxpayer.
Well, I know we can look at the big picture, but prescription drug prices have increased at rates beyond the inflation rate in the last few years.
Absolutely. I have no doubt of that.
Okay. Mr. Smith, your testimony states that Medicare Part D costs are not as high as projected, and I tend to think this because we created the donut hole, forcing seniors to pick up that majority of the tab of their prescription drug medications. Additionally, Medicare Part D plans, the Secretary of HHS cannot negotiate drug prices with manufacturers. This forces seniors in the Part D to pay much higher drug prices. Under H.R. 3962, the health care bill, we close that donut hole by 2019. Farm a statement from Senior Vice President Ken Johnson following the release of the ARP report on prescription drug prices states that what's more, ARP fails to mention that 50% discount that companies will provide to most seniors and disabled Americans who hit the so-called donut hole in Medicare Part D. That provision alone is expected to save beneficiaries spending in the coverage gap as much as $1,800 in 2011. My office has contacted many companies on behalf of our seniors who have entered into the donut hole, and these discounts are not guaranteed and should not be advocated as a benefit to seniors as a way to curb the cost of drugs. Now, we try to work with individual drug companies because we see the ads on TV just like our seniors do, but oftentimes they're not qualified for those discounts when they fall in that donut hole. Do you have information on how many companies provide such discounts to seniors in the donut hole and the average discount they provide?
Congressman, thank you for the question. I do not have information about the number of companies that provide discounts in the donut hole. I can say that under the initiative that we undertook, all companies would be providing the 50% discount on brand drugs in the donut hole.
Well, I know the quote I gave you from Vice President Ken Johnson talked about $1,800. Believe me, I have seniors I talked to Friday in Houston that would love to have that because they fell in that donut hole. If you could get us more information from Pharma on where they come up with that $1,800, I would really appreciate it because I think all of us would like to make sure our seniors, because we do constituent casework, and that's our next option when they hit that donut hole, outside of eliminating the donut hole as our health care bill does. Thank you, Mr. Chairman. I know I'm out of time.
Thank you, Mr. Green. Gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. I think Mr. Shimkus's questioning just a few moments ago really showed to us why this hearing should be on the Subcommittee of Oversight and Investigations, where we can indeed swear people in, get them under oath, so that we get answers that we can depend upon, because we have heard some conflicting information today. I still remain troubled by the fact that we had Pharma, AMA, AHIP, SEIU, AdvaMed down at the White House in May and June doing these deals, some of them, to be sure, part of the public record, but we don't have the phone logs, we don't have the emails, we don't have the minutes from those meetings, and we're in the dark as to what was struck. So when I read in the newspapers that Pharma created an $80 billion deal to help the health care bill get through, okay, that sounds like a good thing, but I don't know what Pharma gave up. I don't know what the White House gave up. It is just difficult to evaluate that. And then, of course, you do have the Congressional Budget Office sitting back there and saying, wait a minute, if you're doing something you should have been doing in the first place, we don't actually score that as a savings. So does that $80 billion decline? I would just like to point out, since I was criticized for about the aspect of negotiation from the Secretary of HHS with Part D. I mean, the Congressional Budget Office, who we should have at this hearing, by the way, they should be here. But they sat at that very table last fall in a secret meeting that we had that wasn't open to the press. The Congressional Budget Office reiterated that direct negotiation from the Secretary of Health and Human Services on Part D prescription drugs would not result in any significant savings. They have said this over and over again. I don't know what we need to do to kill that notion, but it is one that certainly deserves to die. On the issue of the donut hole, Ms. Kramer, I would just ask you, if we did away with that, what would be the effect, the practical effect, on those very low-price policies that are available to people now? In my state of Texas, I think there's some 40 policies that are available for Medicare Part D. What is the practical effect of those very low-cost policies if the donut hole goes away and everything is essentially everything is the same?
If I understand your question, I believe only about 20% of the Part D drug plans provide coverage in the donut hole, and I believe at that point it's primarily for generic drugs.
But a person does have that option to buy coverage that would provide coverage in the gap if they so chose. Is that correct? I mean, that happens today. Well, there is no donut hole for that individual. Is that correct?
Well, that is correct, and as I said, 20% of the policies.
Doesn't use much in the way of medications is free to purchase one of those very low-cost policies that costs a minimal amount each month. And if something happens during the course of that year, yes, they may be, then their out-of-pocket expenditure may not be covered, but they also do have a maximum, a catastrophic coverage above which their drug costs are covered. But because the way Part D is set up, next year in the open enrollment period, they may switch to one of those programs that provides coverage in the gap. Will we lose that flexibility if we go down this road of closing the donut hole as has been outlined in the House bill?
Well, I don't believe so, Congressman. You know, our top priority is to completely close the donut hole because 26% of people enter that donut hole. Only about 3 to 4% really exit that. And during that coverage gap, you've heard the stories about what people do with their drugs when they don't follow their drug regimen. So we think it's extremely important.
I need to interrupt you there for just a moment, because there are other options, and my office certainly works with individuals on an individual basis, as Mr. Shimkus pointed out. There is the option, though, next year during the open enrollment period, you don't have to stay on that particular policy under which you've been covered previously that has allowed you to end up in the donut hole. There are coverages, there are policies that provide coverage in the gap, which would be available to that individual in the years ahead. I'm going to have to move on because there's some other things that I just need to get asked. And first off, Ms. Stoll, I got to ask you the name of that medicine for the migraines. I'm just dying of curiosity.
Of course, I won't be telling you the name of that product. Maybe we can have a private chat later.
See, this is why this needs to be on oversight and investigations, because we could put Ms. Stoll under oath, and she would be required to tell me the name of the medicine, and I wouldn't be left in the dark here.
I'll leave my colleagues to do the paid advertising for specific drugs. But, you know, I want to raise an issue about...
Hold that thought. We'll talk about that privately, because I do have to get one last thought into our two participants at the end. We talk about what may be a causal relationship and what may be a casual relationship. I do think it's important. One of the things we can't know at this hearing, because we don't have access to all information, we can't know what is just a casual relationship between the $80 billion that pharma said they're going to give up and a causal relationship. Hey, if we give up $80 billion, then we're going to be able to have price flexibility to make up some of that ground on something else. We just don't know. So where is the line drawn between what's a casual relationship and what is causal?
Well, that's more of a scientific or statistical question, but I think just from a policy observational perspective, we've never seen drug prices go up this high in the last decade and a half. And this is a time when there's the most risk for drug companies, that is, having either price controls or a change in the market structure in a way that affects their prices. And so it would be logical that they are looking for ways to buffer their revenue for as much as they can and as long as they can.
Again, that's speculation. It would be better if we were all on the record under oath. Let me just ask you one last thing.
Dr.
You said
Burgess,
you've not seen a drug
we're
price
minute
go
over.
down.
We got other questions here.
We did have Prevacid, which went over the counter this past month, and the price drop has been dramatic, and it's still sold under a brand name.
Can we ask you to respond in writing? Because we have a number of members and we've got a vote coming up.
Mr. Chairman, with all due respect, I sat here while many of our panelists, and I appreciate them being here, went significantly over time. This is an important issue.
I understand that the panel.
Things.
I understand that the panel went over time, but I'm trying to keep.
Well, let's have Dr.
Trying to keep the members to the minute. We're going to have a vote at 12:15, and we got a lot of members. So, respond to us in writing, if you will. Next is. Chairman Dingell.
Please, to Mr. Schondelmeyer. Mr. Schondelmeyer, I'm not sure you or the other panel members remember years ago, but we made some changes in the Food and Drug Law which banned the imports of pharmaceuticals which could not be certified as safe by the Secretary of HHS. Do you remember that?
Yes, I believe
okay.
that was back in the 80s.
So the law now says you cannot import pharmaceuticals unless they can be certified as being safe. Is that right?
I believe the law says that.
That's what the law says. So pharmaceuticals can be imported, but they got to be certified as being safe. Is that right?
I believe that's the case.
Okay. Now we have the nice problem that if we change that, unsafe pharmaceuticals can be imported. Is that right?
It depends on your certification process and how good it is.
Well, let's not cavil. If the Secretary can't certify that they're safe, they can't come in. Isn't that right?
Well, they may not be able to certify for political reasons or for practical reasons.
Dear friend, I wrote the legislation. It didn't say political reasons. It just says you can't import them.
I realize
unless they're certified as safe. Are you in accord with that?
In what sense?
Or do you agree that that's good public policy?
I believe there are processes by which an appropriate certification process could be undertaken.
Well, I've got no objection. I've got no objection, but up till now they've not been able to do it. And I don't want to engage in a great big toe dance here. I just want to get the record clear because everybody's trying to re-import, and I keep trying to tell them you can do so if the pharmaceuticals are safe and the Secretary can so certify. And I just want to get that into the record. Am I correct in my appreciation on this matter or not?
I believe you are, but again, okay. I'm not a lawyer to study that.
Thank you very, very much. Now, I note several things here, and very quickly I'd like to get them. There's no trap here, so just please give me a yes or no answer. H.R. 3962 will provide assistance for millions of other Americans to ensure that they can afford prescription drugs. This would have a substantial impact on medical adherence. Is that correct?
I don't know the bills by their number as you quoted it, so I can't answer that, sir.
All right. Now, H.R. 3962 will also close the donut hole. Is that not so? Yes or no?
Again, I don't recall the specific.
I'm not trying to trap you. I'm just asking you facts. You're my expert here. And I'd like to get your help on this thing. All right. Let's go to Mr. Smith. With regard to H.R. 3962, it will provide financial assistance for millions of other Americans to ensure that they can afford their prescription drugs. Is this so or not?
Congressman, it provides assistance. Respectfully, as you know, we oppose the bill.
Thank you. H.R. 3962 will also close the donut hole. Is that not so?
Same answer, Congressman.
Okay. Now, Ms. Stoll, if you please. We sometimes overlook the problems that confront millions of Americans with insurance that fails to cover adequate benefits and protection from financial bankruptcy. These are the underinsured. You mentioned a 60% increase in the number of underinsured from 2003 to 2007. Can you tell us what are the major causes for this jump?
Well, there's about 25 million underinsured as we figure it. A major cause of that is lack of solid prescription drug coverage. A lot of plans in the individual market don't cover prescription drugs. We'll fix that with H.R. 3962, so I applaud that.
Now, we include a number of important provisions in H.R. 3962, such as a minimum benefit package that includes prescription drug coverage, elimination of annual and lifetime caps, assistance for premium and out-of-pocket costs. Would these provisions help address the problems of the underinsured?
Absolutely.
Thank you. Ms. Kramer, if you please. I'd like to highlight your comments on Medicare Part D, the donut hole, the point at which beneficiaries are responsible for the full cost of their prescription drug. You state under current law the donut hole is projected to almost double by 2016 to more than $6,000. This means that Part D beneficiaries can find themselves paying the full cost of their drugs far longer in the future. This is quite unsettling to me. H.R. 3962 provides a 50% discount on brand name drugs in the donut hole, reduces the donut hole by $500 in 2010, and eliminates the donut hole entirely by 2019, and authorizes the Secretary to negotiate on behalf of seniors for lower drug prices in Part D. Give me your judgment. Are these steps sufficient to avert the substantial donut hole growth that you have referred to by 2016 and to provide necessary and needed relief for our seniors?
Yes, Congressman, it completely closes the coverage gap.
Thank you.
Mr. Chairman.
My time has expired, and I thank you for your courtesy.
Thank you, Chairman Dingell. Gentleman from Pennsylvania, Mr. Murphy.
Thank you, Mr. Chairman. Dr. Schallenmeyer, do you have any research that's funded by NIH? Are you involved in any research funded by NIH?
No, I have not conducted research in the lab, which is primarily the type of research conducted by NIH.
NIMH, National Science Foundation, anything of that sort?
I've had research funded by the Centers for Medicare and Medicaid Services.
Okay. When that's done, what percentage of that research is there to cover overhead costs?
What percentage
of your research grant is funds overhead costs, do you know?
The University of Minnesota has a negotiated rate with the government that's like 51%, I believe.
So 51% is not involved in the actual research, but it goes to the overhead.
That's negotiated between the government and the
That's a standard actually for NIH grants too across the country, about 51%. As a matter of fact, I found it interesting that some universities, such as Harvard, have a 71% overhead rate, MIT 67%, University of Minnesota is around 50%. It concerns me that so much money is set out to do actual research, but over 50% goes to things that have nothing to do with research. Should we stop giving universities money for their overhead at these outrageous rates of nearly 2/3 or half or more that doesn't even go to taking care of the things they're supposed to do? What do you think?
Well, first, as a mischaracterization, the 51% overhead means about 1/3 of the money goes to overhead. It's 51% on the
It's facilities and administrative. Yeah, we're paying for buildings. I'm just asking, should we cut that so that universities should only use their research money to go directly to research and not go to pay other things to run the university? What do you think?
No, those overhead costs do pay direct costs that are indirect costs that are related to the cost of conducting that research. In fact, University of Minnesota estimates
a lot of their costs, that the universities get in these things are not necessarily going to the research, which is helping save lives and develop new drugs, things like that, but we should keep paying that when it's not really going. I mean, some of it goes to university president's salaries. Some of them make quite a bit of money, I understand. Should we stop doing that?
I'm not a university president, so I don't know.
Okay, all right. Well, we'll just keep you within your line. Ms. Kramer, on the AARP Board of Directors, you have responsibility of oversight over the insurance plans that AARP contracts with some of these companies. Does AARP have a Medicare Part D plan?
Yes, we do.
And who do you contract that with, or do you run it yourselves?
With United Health Group.
And what is the percent? Well, how much do they pay AARP in royalties or whatever you would call it to run that? To you have to offer that plan.
I don't have that number with me.
You're a member of the board. You just told me you have oversight over that. You tell me that something that is a massive amount of the income for AARP, you don't know how much it is?
I don't know what portion is for the Part D plan.
Dollar amount? You don't know?
Congressman, I've answered. I don't
know. No, you haven't answered my question.
What portion is
you
for the
said
Part
that this
D
is
plan.
over half of your income comes from insurance plans, but you have no idea how much it is, and you're on the board. I think you chair the board. And you're telling me you don't know what kind of money AARP makes? I don't understand that.
Well, I've answered to.
Well, let me ask another question because I'm trying to get an answer to that. So, do you have a donut hole in your plan?
I'm sorry?
Do you have a donut hole in your Medicare Part D plan?
Yes, we do.
You do. And yet you make millions and millions and millions of dollars out of your Medicare Part D plan. Why don't you use that money to fill the donut hole?
Our plans operate within the federal and state laws just
well,
like
no,
any
I'm
other
asking
plan
you,
does.
well, federal state law allows you to have a plan that does not have a donut hole. Why don't you fill the donut hole with the profits you make? After all, you're a nonprofit organization. Why don't you use that money? I understand your executive director makes how much money for AARP?
I'm sorry?
How much does your executive director get paid per year at AARP?
He doesn't get paid what the Senate said.
How much does he get paid? How much does he get paid?
I'm not going to. I would be glad to answer that offline.
I don't understand why we can talk about everybody else's salaries but AARP's. And you're here criticizing other companies. Look, here's the thing. We know that drug companies, it's my time. The drug companies, I'm concerned about the cost of drugs. And I'm concerned how much it costs people. But I want to get to the bottom of this. And so you have the cost of manufacturing the drug. You have the profits company make. You have research and development for those drugs. You have advertising. I want to get to the bottom of that. But there's also the cost of administering plans. And AARP is not an innocent partner in this because you also make a lot of money from this. And when I ask you how much your director makes, suddenly that's off limits. But we can talk about how much money pharmaceutical companies direct. I don't know how much money AARP is putting into your pockets and how much is going to doing such things as eliminating the donut hole, reducing prices. What this committee needs to do is look at all of these levels. And I think it's disingenuous for AARP to come here and say, when it comes to AARP, we're not telling you how much money we make or what we do with it, or for some reason the chairman of the board doesn't understand that stuff.
I believe
but when it comes
audit
to talking about when it comes to talking about these prices, everything should be on the table. I'm deeply concerned about senior citizens who cannot afford drugs. I'm deeply concerned about members of AARP who cannot afford drugs. But you're telling me a lot of this goes into your profits. You won't tell me how much your executives make in salaries, and you won't close your own donut hole. And I yield back the balance of my time.
Congressman, I believe our audited report was just entered into.
You're not going to answer my questions. You don't.
And the executive director's salary is
she's not going to answer my question.
Well,
doesn't have time.
look. If she wants to answer the question,
Mr. Chairman, she's told me she doesn't have the answers to these.
Well, Ms. Kramer, if you'd like to answer, you can.
Well, as I said, I believe our audited report moments ago was entered into your record, which would include the information the Congressman is asking, and also the 990, which is public document, would include the information on our executive director's salary. I also said that it's around $800,000 per year.
Well, why don't you use that money to close the donut hole?
All right, well, she tried to answer your question as best she could, and we do have the documents that were entered into the record by Mr. Shimkus. We have about, I guess we still have another 13 minutes or so, so I'd like to get a couple more people in. Ms. Capps is next.
Thank you, Mr. Chairman, and I want to spend most of my precious 5 minutes on the topic of medications used to treat cancer. But I want to give you a chance, Ms. Kramer, to talk 1 more minute or less, hopefully less, on the donut hole, because in your written statement you reference AARP's donut hole calculator. Just to get it on the record for today's discussion, would you very briefly tell us what that is?
It is a new online tool that became effective in July. It is found at donuthole.aarp.org. It helps individuals calculate and track their out-of-pocket expenses. It helps individuals locate cheaper alternatives for their condition. It provides a personal medication record, and it also provides personalized letters if individuals decide they want to pursue cheaper generics. It helps them begin the conversation with their doctor. It's extremely popular. We have served almost over 180,000 people since it came online in July. That's 1,000 people a day.
Thank you very much. There was an article in the New York Times this weekend, pretty disturbing one, about the high cost of drugs treating cancer. And it reported that a new medication called Folotyn is going to be sold for about $30,000 a month. Now, for the record, drug companies should be able to make a profit. We need a profitable and successful domestic pharmaceutical industry. But I'm going to ask you, Mr. Smith, what good do breakthrough treatments do when they're unattainable for almost all the people who need them most? Is there any point at which your industry simply says, no, we can't charge this much?
Congresswoman, drugs absolutely need to be accessible for them to do good. That's one of the reasons that we're trying to, help support a health reform bill. In terms of this particular issue, I don't know anything about this drug. I don't know this company. But what I can say is that there are certainly cases where there are high-cost drugs, and these medicines, patients need high-cost medicines at times, just like they need high-cost hospitalizations and other services.
Let me ask you. Go
I'll
ahead.
get one sentence out, if I might. And part of what we do with insurance is spread the risk across the entire population for the few people who need high-cost services.
This is a pretty big risk for a few people whose lives are hanging by a thread. Here's the shocking part of the story as it was reported in the newspaper. The drug hasn't even been shown to increase the life expectancy of those who take it. If a manufacturer is going to charge $30,000 a month for a drug, I would think that they would want to be able to show that at least helps patients live a little bit longer. Now, you've answered, and I want to use whatever time, and it's only 2 minutes, to see if others on the panel would like to respond to this particular issue, either using this story or one other one. But I'm focusing particularly on life-threatening diseases that are lumped together as cancer and the way the cost of treatment has gone up. Dr. Chandamali, you might want to speak to it, or maybe Ms. Stoll too as well.
Sure, I would. First of all, I did not see that article in New York Times this weekend. I will go back and look for that. In our own study, the 12 cancer drugs that we had in the specialty area, those 12 drugs all went up in price, and the price increase in 1 year ranged between 4.9% up to as much as 20.8% increase in price in a single year. And then that compounds over time, of course, as prices keep going up. I think the point you raise is one of, we have to assess what is the real marginal value that a drug adds to society. And I'm going to shift away from a cancer drug, but I think it's the same principle. A drug called Zetia, which is supposedly used for cholesterol, we've recently found that that drug really is not as effective as we thought, and not as effective as an old drug that's very inexpensive, even though it has a small convenience type side effect perhaps. But Zetia itself was able to raise their price dramatically in the marketplace, even though it's not even effective.
Let me see if Ms. Dole, what do you think we should do now? How can this legislation of health reform address this particular egregious issue?
Well, there's a number of drugs that are expensive, like this one in the New York Times article. I think part of the answer is, again, we need to get everyone into the system. We need to have a pooled program where we're sharing costs. Not everyone's going to need these expensive drugs. We need prescription drug coverage with annual and lifetime limits. And we need special and lower limits for low-income people to protect them so that their access to this drug and other drugs like it are not limited. And I think that's where you find in this sort of back and forth between good and bad today some common ground among all of us and wanting to see that everyone's in the system and has out-of-pocket protections so they can have access to drugs. Now, drugs should be evaluated to make sure they bring more value and new value to what's already on the marketplace.
Thank you very much. I yield back.
We have 7 minutes left. I'd like to get Mr. Boyer in, if that's okay. Assuming that the other members will come back after the votes. We have 4 votes. Mr. Boyer?
I've got 2 questions of 2 different witnesses. One of the Professor Vernon. I want you to think about this. Then I've got some questions of Ms. Kramer. In my opening statement, I made some comments regarding the impact of price controls in the European Union. It's been part of your studies. And now that you've had a chance to examine H.R. 3962 and some of the price controls and the comparative effectiveness that is in that bill, I want you to talk a little bit further about the potential impact of those controls upon drug pricing and whether it has a positive or negative impact upon public health. Okay? Secondly, Ms. Kramer, I'd like for you to respond. Number 1, I'd like to know whether AARP, whether your organization has produced, request, or received any estimates about how much additional revenue per annum will be created to your organization by H.R. 3962. I'd also like to know, that's number 1. Number 2, I'd also like to know whether your organization had any contact with this committee, or their staff relative to the sweetheart deal that you have in Section 102 of H.R. 3962, i.e. most insurance plans are required to have a medical loss ratio of 85%. However, this bill that passed the House allows Medicare supplemental insurance plans, such as AARP's Medicare supplemental insurance plan, to have a medical loss ratio of 65%. I'd like to know whether or not your organization had any contact in the advocacy of that. And I'll give you a chance to respond. Professor?
Thank you, Congressman. I'd begin by saying you had referenced my study with Professor Golick at the University of Connecticut regarding the exodus of R&D investment from Europe to the U.S. That is certainly true. I mean, we've seen regulations of pharmaceutical prices in the EU become more stringent. The U.S. now being largely the only price unregulated market for pharmaceuticals in the world, and certainly, the prize in terms of both basic research, which could be done globally, but specifically later stage research, large clinical trials, and marketing networks, as well as a familiarity with how to get through the FDA process, has resulted in a lot of R&D leaving Europe and coming to the U.S., and as a result, we've seen a dramatic change in the levels of R&D comparing the two markets. And then also, generally speaking, regarding the legislation, any attempt, implicit or explicit, to control drug prices, there have been bills on reimportation, technology assessment, and perhaps negotiated drug prices, does represent a very serious threat to the incentives to undertake R&D. And to be frank, it's remarkable research by economists at Yale and the University of Chicago have shown that the benefits of pharmaceutical innovation and medical innovation have been astounding and far exceed the levels of investment and the cost of that investment, suggesting we should be doing more medical research, more pharmaceutical research, because the benefits exceed the costs. Now, that being said, I'm not denying the fact that cost containment measures would benefit consumers of existing medicines that are on the market. It would make them more affordable, improve access and utilization, and improve health. But I think we have to consider that cost and that benefit, and specifically that benefit of lower cost medicines today, with what it would mean for the rate of innovation in the future. And I think the latter is an order of magnitude greater than the former, based upon the empirical research out there. Thank you.
All right, thank you. Ms. Kramer?
The answer to both of your questions is... I'm sorry. The answer to both questions is no. We have not, to my knowledge, had any estimate of revenues that AARP would lose or gain under House Bill 3962. And I have checked with staff. To my knowledge, there has been no contact with the committee. Looking at the medical loss ratio, we advocate on behalf of members.
The Congressional Budget Office has said that H.R. 3962 will result in fewer people enrolled in Medicare Advantage. Fewer really is 3 million. And more people enrolled in Medicare Part D. Isn't it true that the vast majority, probably up to 80–90% of people enrolled in Medicare Part D buy a supplemental insurance policy such as the AARP Medicare Supplemental Insurance Plan offered by United Healthcare?
Are you asking me?
Wow. Who else would I be asking?
Well, Congressman, I don't work for United Healthcare, so I don't know that I can answer that question.
Well, I find it really hard to believe. Well, first of all, there's going to be a tremendous shift to supplementals for which you offer. And I cannot believe that you run an organization that you've never really calculated what the potential income flow to your organization will be. That is really, really surprising to me. I guess you're just trying to guard yourself in exchange for questions about why you endorse the overall packet, but I think it's now obvious. I yield back.
Thank you. Now, we're going to have 4 votes on the floor, maybe half an hour, a little more. I'm assuming that some members are going to come back. So if you would wait, we'd ask you to wait, and the subcommittee will stand in recess.
This is actually, yes, very nice. 1/2 hour. Yeah, I think this is actually quicker and more efficient than we usually see. So, yeah. Precise. Yeah. Yep. Same here.
We didn't have a timer.
Oh, they didn't give us a timer?
We didn't have a timer. But I actually was, that was pretty good.
We ran 3 minutes over. I don't think 3 minutes is the issue here.
What's that? It doesn't feel like you having fun? No, I'm not. I'm bored as shit. I'm sorry you didn't hear that. No. Well, I mean, you know. No one is talking about supporting R&D. Talked about the volume issue. 36 million customers plus government, 25 million ambulances. But nobody said that, and I couldn't get it in. I couldn't get in. I put it in. I'm trying to keep it in. I couldn't get it in.
Oh, I just thought I was hoping it